Bismillah ar-Rahman ar-Rahim. Good morning, distinguished guests, respected colleagues, and dear friends. Standing here today fills me with immense pride and gratitude. Yesterday, we witnessed the opening of a historic event, the first Emirates Diabetes Educator Society Conference 2025, a milestone that reflects not only years of dedication, but also the spirit of unity and vision that brought us all together. Today, we will continue under the theme Bridging Disciplines, Collaborative Excellence in Diabetes Care. We will begin with the latest ADA 2025 updates, followed by sessions on inpatient care, pregnancy, obesity management, and diabetic foot care. Later in today, we will explore new diabetes technologies, patient-physician communication, and translational research that connects evidence to real-world practice. Before we start, a quick reminder, please keep your phone on silence during the sessions. Question and answers will follow each session. Certificates will be sent to your emails after completing the evaluation form. And don't forget to share your moments in the conference using hashtag DAS2025. I would like to call the first moderators for today's sessions, Ms. Zainab Al-Abadla and Dr. Mohammed Al-Ibyari. Please come in.
Good morning, ladies and gentlemen, and welcome to Session 4, Bridging Disciplines, Collaborative Excellence in Diabetes Care. I am honored to co-chair the session today with Dr. Mohammed Al-Abyari, consultant of endocrinologist at Al Jalila Children's Specialty Hospital, who happens to be my head of department as well. So imagine how fun it is to co-chair the session with your boss. I promise to behave myself today. Together today, we will explore how teamwork among diabetes educators, clinicians, specialists enhance the outcome of people living with diabetes. You will hear from expert professionals whose expertise truly represents the strength of multidisciplinary team approach. To begin, I am delighted to introduce Dr. Ali, consultant in diabetes and endocrinology at Mediclinic City Hospital and associated professor at Mohammed bin Rashid University. Dr. Ali will share essential insights from the ADA guidelines, key insights which every educator should take note of. Dr. Ali, floor is yours.
Thank you very much, Zainab, for the kind introduction, and a very warm congratulations to you all for this amazing conference. It's truly awesome. I was just discussing with my colleague now that it is finally a very good platform for you and us to meet. So, without further ado, we'll talk about the evolution of guidelines and also the current guideline and what you should know. I'll start with a question just to keep it a little bit lively. What's the main cause of death in people living with diabetes? Is it hypoglycemia? Is it DKA? Is it renal failure, cardiovascular disease, or frailty of old age, like our patients are living for until they are old? So if you feel it is hypoglycemia, raise your hand. If you feel it is DKA, raise your hand. Okay. If you feel it is renal failure, raise your hand. Good. If you feel it's cardiovascular disease, raise your hand. Wow. I need to go home now. Or if it is frailty of old age. So certainly cardiovascular disease is by far the biggest cause of death in people with diabetes. If you look at this analysis of a cohort, you see, here, okay. So you see non-cardiac death, it's 3.1, malignancy 13.9, which is a huge in people with diabetes. But look at the cardiovascular related, presumed cardiovascular death, cerebrovascular, like strokes, heart failure, acute MI, sudden cardiac death. 2/3 of our patients, unfortunately, are passing because of this. So this led to the evolution of the guidelines. We used to say, we need to use the best treatment for this patient to get their sugar in the best kind of shape and form. And this was the the 2016 and before guidelines of the ADA. And then from then, started to evolve in a way that it became more patient-centric and concentrating on things that are mattering to our patients. So early on, we started to hear about the cardiovascular health and death, then about the independence from HbA1c. We want to get the patients the best treatment, regardless of what is their HbA1c. And now, if you look at now, the guidelines concentrate holistically on the whole patient, taking into consideration their immunization, taking into consideration the liver health, the cardiovascular, the sexual health, technology integration. So it's now more holistic. We are looking at the whole of the patient rather than concentrating on a figure, which is what medicine is about. And this is kind of the pyramid of care from ADA. This is, you see it in the guidelines. We need to provide best glycemic control for our patients, and certainly this is something we all collaborate on. Best blood pressure management, best lipid management, and more recently, adding agents with cardiovascular and renal benefits is indicated. But look at what's happening. This is all on the basis of lifestyle modification and diabetes education. So your role is the basis of all of that. Whatever medications we give, if lifestyle is not meeting the needs, that won't work. We'll not get the best outcome from our patients. So it's more of a holistic approach. We need to concentrate on lifestyle, and from there, we can do the remaining. So the guideline is huge, and we all have access to it. It's free online, but I've taken some snippets that are useful to all of us so that we can integrate in our care. So the first one about screening for type 1 diabetes. And screening for type 1 diabetes is, we all know about it, but there are a few things that to take into consideration, especially that now we have medications that enable us to delay diabetes onset if the patient is in stage 2 type 1 diabetes. So people, the first degree relatives of people with type 1 diabetes, we should advocate for screening for them. And people with ketoacidosis, with hyperglycemia or euglycemia, we should also get their antibodies done. If someone is not responding to treatments and they are taking the treatments well, there may be something wrong. Maybe they are insulin deficient. We need to check for type 1 diabetes. It could be type 1, it could be LADA. People with diabetes who try to lose weight and suddenly they are able to lose weight very quickly, it should be a worry for us. We all know that losing weight is very difficult. So we need to check for type 1 diabetes. And most recently, over the past 10 years or so, we started to use checkpoint inhibitors in treatment of cancers. Any one of those patients, if they start to have hyperglycemia, we need to check their antibodies as well, because they could be developing autoimmune type 1 diabetes. So this is for type 1 diabetes. We check for GAD, islet antigen 2, and zinc transporter. For type 2 diabetes, I was pleasantly surprised to see that anyone above age of 35 needs to be checked for type 2 diabetes. This is because of the huge prevalence. So if we detect it early, we can treat it early. And anyone with a body mass index of 25 and above, or from an Asian extraction with a body mass index 23 and above, with one or more risk factors like history of cardiovascular disease, first degree relative diabetes, low HDL, we know this is a risk factor for type 2 diabetes, or high triglycerides, physical inactivity, and all of us, unfortunately suffer from that, and hypertension. So any risk factors for cardiovascular disease, also we need to check for early or pre-diabetes as well. People with impaired fasting glucose, we need to do it every year. People with gestational diabetes, we need to do it every year. And also, if there are certain treatments the patients are on, we need to check for diabetes. And probably you play a role in reminding us and when to check for those patients if you are aware of those. This is the famous guideline that we see every day and in our kind of practice. And this is kind of our Bible that guides our practice. But I want you to concentrate on the first line here. Again, we start from lifestyle. We start from you. This is the most important part. We choose the medications for whether the patient has atherosclerotic cardiovascular disease or if they are at risk of that. We choose, this would be GLP-1s and or SGLT2s. If the patient has heart failure, we should use SGLT2 inhibitors first, and if they have CKD, we use SGLT2s or GLP-1 receptor agonists with proven benefit. If there is excess weight and so on. So the guideline is very simple and logical and goes straight forward, but the start is here. And what is education about? I mean, it's not that I would remind you of what you do every day, but this is the guideline now, outlines, these are the core tenets of the education. We need to educate the patient about their disease. Why do they have, what is the pathophysiology of type 1 diabetes and the treatments they are taking and how do they work? Because once they understand that, they will work with the treatment rather than they feel it is a burden on them. We need to teach them how to cope with their disease, with their illness in a healthy way. We need to teach them about healthy eating, about being active in a safe way. We need to teach them how to take their medications and to take them regularly. Compliance is important. Monitoring of their diabetes, and this is a huge, because if you don't monitor something, you don't know how to, if you are treating it right or not, and how to reduce the risk. And I really like this one, problem solving. The last one. Here we go. So problem solving, because a patient may bring a scenario to you, you will give them the answer. They can bring another scenario to you and you can give them the answer. But they are living with diabetes. They will face certain things that they haven't come up with before. So if they know how to problem solve in a safe way, that's a very, very strong life-saving skill that you can pass on to your patients. And when do we need to do all this training? Every year, or when the treatment goals are not met. So reminding our patients with all those principles so that they continue to have their care in check. I'm not going to go through those details. Probably you know about them more than me. There is focus on the carbohydrate rich with fibers. There is a focus on reducing sugars. There is a focus on having fluids that don't have sugar in them. But the thing that I want you to focus on here is, this one. So insulin dosing. If the patient is on insulin and fixed dose insulin, and this is, by the way, used less and less nowadays, the likes of Novomix or Ryzodex, so mixed insulins, we need to focus on the patient's intake of their food regularly. We are all advocates of flexible living and choice and so on, but if they are taking fixed dose insulin, they need to take their food regularly with carbohydrate matching that, otherwise they will end up with hypoglycemia. And the second one is GLT2 inhibitors. If your patients want to lose weight, ketogenic diet is out of the way. They could end up with ketogenic, they could end up with acidotic ketosis. With regard to proteins, there is more push for plant-based proteins, and if we will go for any animal proteins, it would be based on the Mediterranean, and we should limit the saturated fats as much as possible. And I really like this slide. This is about being active and physical activity, and it shows by evidence what does activity do to our patients. From standing from a prolonged sitting to stepping to having vigorous exercise that will enable you to sweat. And I always tell my patients, your exercise becomes exercise when you start to sweat, or when they are doing endurance and strengthening activity, as well as sleep, duration of sleep, quality of sleep, and chronotype, the time during the night. And this is rooted in evidence. If you see in the first slide, the glucose and insulin, it has a very strong evidence base for benefit. It reduces the glucose if you step from sitting, if you do exercise, if you stand, if you do endurance exercise, but sleeping as well. Sleeping is very important. Look at that. It improves the glucose and insulin, and that's not a medication. That's something we do every day, but if you do it right, you reflect better on your sugar. Same for blood pressure. Same for HbA1c, same for cholesterol, same for physical function and independence, especially in the elderly. Same for mental health and quality of life. So these are simple things that, it's with very simple access by our patients. If we show them this, it will help them kind of utilize it to their benefit. Technology, there is a lot of push for technology, and I'm very pleased to see this. We can give technology to our patients at a very early stage of their diabetes. We can initiate CGM at the outset of diagnosis for type 1 diabetes. And also, we should encourage those devices, but also make sure that caregivers and patients are very well trained. Because these are devices, and if they are used wrongly, they can do damage. It's like a car. If you don't know how to drive it, you're likely to do an accident. So you need to be taught how to drive it, and you are the soldiers who are doing that for our patients. Doctors, me included, every one of us, need to be competent on those devices before we are able to prescribe them. Otherwise, again, we go to the same problem of becoming more dangerous than beneficial. Students in schools, we should advocate for them. Some schools say you should not have a mobile device on you or something like that, but we should have concession and support those students, because these tools enable them to have a nearly normal activity in school and in their life, and that will help them grow socially, spiritually, mentally better, instead of feeling isolated or not able to do things. So that we should advocate for. And early initiation, and I really, really like this one. Not only CGM, if there is indication for a pump, we should give it. If there is an indication for automated insulin delivery, we should give it, in addition to the training to the person and their caregivers. You may know this, but I'm sharing it if you don't know. This is for finger prick testing, and finger prick testing is not always accurate. It is accurate if there are no interfering materials. So if maltose and galactose are there, they could push the sugar up. Same for NAC. NAC, people use it for as an IV supplement to improve health. Some people take it as an expectorant when they have cough. Acetaminophen, paracetamol, when we have it, it could push the sugar up, and in some meters it could push it down. Dopamine. Uric acid, if people have high uric acid, they may have falsely high sugar, and in some meters it could be low. And if the patient has anemia, so it could give high glucose. On the flip side, if the patient is on diuretic like furosemide, or if they have vitamin C, and especially some people take like 1 or 2 grams a day, which is a huge dose, or if the hematocrit is high, like in polycythemia, then the sugar could be falsely low. So just be aware of those. And on the other side of the CGM, those are also important to keep in mind. So if there is paracetamol there, if the sensor is Dexcom G6 or G7, if we are exceeding 4 grams of paracetamol, this could give falsely high sugar. And with the Medtronic sensors, any dose could interfere with the glucose reading. Ascorbic acid seems to affect more the Freestyle Libre. If the patient's taking more than 500 milligrams in a day, it gives false high readings. And if it is more than 1,000 for the newer generation, like Freestyle Libre 2 Plus and the 3 Plus, so they are more resistant to vitamin C. Hydroxyurea, which is given to some patients like in polycythemia or Provera, can push the sugar high in Dexcom and Medtronic. And mannitol and sorbitol is used mainly in dialysis. Again, this may affect the accuracy of the sensor and give false high readings. With regard to blood pressure management, now the target is 120/80. If it is above that, we need to advocate for lifestyle interventions, and you are our soldiers there. We need to advocate for weight loss. We need to advocate for adequate diet, the likes of DASH diet, where we reduce sodium, increase potassium to suppress aldosterone, reduce alcohol intake, any other living habits that are not good, like smoking, and encourage physical activity. But if blood pressure goes beyond that, we should start treatment early on. We should not delay it. We may start with a single agent, but if the blood pressure is too high, we can give 2 agents. We'll not go through this one, it's there, but it is logical. You can follow it if you want to learn how to manage blood pressure for our patients. For lipids, again, we need to advocate for lifestyle modifications, weight loss, Mediterranean or DASH diet, reduce saturated fats, encourage omega-3 based fats, fiber-rich foods, and physical activity. And we should start a treatment if cholesterol is high, aiming for an LDL less than 70. And if there are any effects before, we should aim for LDL of less than 55 if there is established cardiovascular disease for secondary prevention. Couple of points to mention from your side. For statin therapies, which are very, very widely used, make sure that you counsel your patients, and we should do as well, about grapefruit, especially grapefruit juice, because it increases bioavailability, could result in muscle damage to our patients and other toxicities. And for bile duct sequestrants like cholecyvalam, cholestyramine, they should avoid taking other medications in close proximity to it. Renal disease, same story. The starting point is lifestyle. Healthy eating, physical activity, smoke cessation, weight reduction. So this is the starting point for caring for patients with diabetes and renal disease. Different treatments are advocated. SGLT2 inhibitors and metformin if the eGFR allows, and progressing from there to GLP-1. But also looking at blood pressure treatment, the right blood pressure combinations to allow blood pressure to be well controlled, looking at antiplatelets, giving the statin therapy that is required, or like lipid lowering agents that's required. And these are some of the measures that we use to reduce albuminuria by having good control of blood pressure, good control of sugar, starting ACE inhibitors or ARBs, and lifestyle habits, the likes of excessive smoking, reducing weight, and having healthy diets, as well as right treatment. Retinopathy need to be done every year, but 5 years, starting 5 years after diagnosis in type 1, and in type 2 diabetes at the diagnosis moving forward. But in the future, and now it is happening in Dubai now actually, using AI for assessment of retinal screening is available. And this will become more and more accessible for our patients. In the elderly, again, there is focus on managing diabetes in a safe and effective way, looking at the 4 M's, mentation, the mental capacity, the mobility, the medications, and what matters most for patients. There's a lot of details there which we can go through, but the principle behind it is if you give anything to our patients, it needs to be digestible. If you give them any treatment, they need to understand it, they need to be able to do it. If they are not able to do it, we need to give them the right support to do it, ensure their mobility, and ensure a good system for taking medications right, and ask them what they want. If we want to give them best control and they will feel miserable if they take an injection, probably that's not the right approach. And these are some of the guidelines. We will not go through all that, but I just want to concentrate on this last one. If someone has very poor complex health and life span or life expectancy is short, please don't go for strict control of diabetes. The idea here is to make it asymptomatic. We don't want them to have hypos. Hypos are no-no. We don't want them to have high sugar and get osmotic symptoms, feeling thirsty, passing lots of urine. So just keeping them asymptomatic would be a very good success to the treatment. And if they are healthy and they are 80, we should treat them as if they are 40. We should not allow the sugar to go very high just because of age. And this is what the starting point is. In hospitalized patients, I'll not go through it because one of our colleagues are there, but it focuses on ICU and out of ICU targets for our patients. And the principle there is empowering patients. And if they have any devices, we should continue supporting it there. But we need to have institutional policies for that, and the people in the hospital, nurses, doctors, need to be trained on those devices if we are to allow them to continue to function. And last one, which is very important, I think you will be kind of the main drivers for this. It's immunization, and adult immunization is not a new concept, but it's gaining more traction recently, because our immune system, and this is a fact, become more senescent after we cross the age of 50. And if you have diabetes, your immune system would be weaker. And therefore, like providing any layer of protection is very important. So if you have, the guideline, ADA guideline now advocate for hepatitis B, for respiratory syncytial virus vaccination from age 60 and above. And here in Emirates, that the guidelines say from age 50 and above. So it's even more going one step further. The annual flu, we should all get it, including our patients with diabetes. The booster for the diphtheria, tetanus, and pertussis need to be given every year. And zoster treatment, zoster vaccine is also advocated by the ADA from age 50 and above. Again, for our patients with diabetes, the DHA just published their new guideline from age 18 and above. So we can provide this protection for our patients from an earlier age. For COVID, we all know this. For the pneumonia, there are different pneumonia vaccines, but we should, offer it to our patients from age 19 and above. The take-home messages. The starting opening, statement was, we are partners in care. We are here to care for our patients with diabetes, and technology is moving fast. And I would not be surprised when we have like a completely autonomous system. So the role of like titrating the insulin up and down will not be the main role of us. We need to be prepared for a future where our role will be evolving and changing. We need to be dynamic. We need to learn new things. And the likes of AI, we need to be masters of that because it will be our tool in the future. And the most important thing, we should advocate for our patients' best outcomes. Thank you very much for attention. I'm happy to take questions.
Dr. Ali, for the insightful and informative presentation. I think we can take one question from the audience and one question from here. So who would like to have the, yeah, please.
Yes. So grapefruit juice, grapefruit in general have something that suppresses the enzyme that breaks down statins. And if you take a fruit itself, as we know, fruit is okay, like, you will have some of it. But juice means like few fruits are squeezed. So you're getting a big dose of that enzyme suppressant, which means if you are taking, atorvastatin 40, the bioavailability of that becomes about 100 to 150 or thereabouts. So the level becomes very high. And that could cause rhabdomyolysis, could cause, liver injury and things like that. And this happens only in big doses of a grapefruit. So like 1 or 2 pieces of like a fresh fruit, it's okay. But bigger amounts is not.
Thank you. I have a question, Dr. Ali, for you. Which of the ADA 2025 updates do you think will most influence the clinical education practice this year?
I think the starting point, if you see, when we start at the beginning, it starts with you, with education, with providing the best approach to our patients. We have amazing treatments, GLP-1s, absolutely amazing, SGLT2s, but all of those will have no meaning whatsoever if the patient is not using it right. So starting with a good base, with lifestyle, with understanding those treatments, the education, back to the same point, will make the biggest difference. And that's in my opinion. Yes, those new treatments and when we use them in the right way is important, and this is kind of what we do every day. But this lifestyle part is always underestimated, and it cannot be underestimated.
Thank you so much. Thank you for highlighting the importance of education among multidisciplinary team. Thank you.
Thank you.
So thank you, Dr. Ali, for an excellent and comprehensive update. Good morning, everybody. it is my pleasure to introduce the second speaker. However, just before I introduce the second speaker, I wish to make a comment, because the idea of the Diabetic Educators Conference was, to me, when I heard that, Zainab and her team are doing it, you see, I was really thrilled. I have always, I've been practicing diabetes for so many years. I'm not going to tell you how long. And I totally believe in the educators, dietitians' roles in managing diabetes. It's not the physician, actually, well, at least I know I'm talking about pediatrics. It's not the physicians who are the frontliners, It is the educators and dietitians, who have continuous support, and are in touch with the family. So thank you for your passion that turned, dreams into reality. Now, right. So it is my pleasure to introduce Dr. Ala Bashir, consultant internist and endocrinologist at Dubai Hospital and DHA Academic Health Corporation. Dr. Ala will share his perspective on strengthening the educator's role with inpatient care. Dr. Ala, please.
Assalamu alaikum wa rahmatullah. First of all, I'd like to congratulate you all on this amazing conference. And thank you for inviting me to give a talk on the role of diabetes care specialists in the in-hospital management. And before I start, I'd like you to agree with me on something before I go forward, because if you don't agree, I'm not going to do my talk. And I think calling diabetes educators as diabetes educators is not right. Because in that way, we limit your role to only education. I know education is the core of your business. And if you look at the algorithm Dr. Ali just showed right now, it starts with education. But there are a lot of roles that diabetes specialized nurses do play within the team. So you agree with me that the name should not be a diabetes educator and it should be diabetes specialized nurse, right? So my talk is basically, when we talk about the role of nurses within the hospital, it's basically education, but you are as well motivators, and you are caregivers, and you are collaborators within the team. And when it comes to in-hospital management, things are a bit different, and I'm going to discuss why in-hospital management is a bit different than outpatient practice. Basically, if you look at the number or the amount of admissions or number of patients with diabetes who has been admitted to hospital, almost 40% of hospitalized patients in US have diabetes. And that patients with diabetes who has been admitted has actually twice the cost of in-hospital, the in-hospital cost. And basically the cost is related to the high rate of hospitalizations. Patients with diabetes get admitted frequently. They have a longer stay in the hospital, and they have greater number of procedures and complications. In addition, they have chronic complication that requires treatment in itself. And not only people with diabetes, we have the group of people who have stress hyperglycemia, which accounts as well for around 12% of all patients admitted to hospital. Unfortunately, you would see around 37% of all patients with stress hyperglycemia admitted to medical ward, and almost 1/3 of people admitted to surgical wards having stress hyperglycemia. And unfortunately, 93% of those patients remain undiagnosed and will not receive treatment until discharge. So what are the outcomes if a patient had hyperglycemia or diabetes? And this is a study done long time ago on 2,471 patients with a community-acquired pneumonia. 11% of them had a blood glucose of 198. So what we found that there is an increase, 73% increase in mortality if they had hyperglycemia, and there is 52% risk of in-hospital complications. That translates to any increase of 1.98 milligram in blood glucose is associated with 3% risk of in-hospital complications. So, what are the possible complications? There are many complications, but if we tightly control the blood glucose, whether in ICU or in the wards, general wards, there is a significant reduction of complications. So there is a way to work on. If this is a study by Vandenberg, who evaluated the tight glycemic control in ICU setting and found that if we tightly control patients, we reduce neuropathy by 44%, we reduce the blood transfusion by 50%, acute kidney injury by 41%, sepsis 46%, and ICU mortality by 43%. So any hyperglycemia in hospital should be managed. And when we talk about hospital management, we don't talk about long-term complications. We talk about just the period of hospitalization. And this is the survival. If a patient got tightly controlled, you see there is definitely an increase in survival if we used intensive regimen or in-hospital survival. So now, we'll now shift to what's the diabetes educator or specialized diabetes nurse in hospital. This is just data about the diabetes impact in the hospital. And this is in 2020. In the US, they found that most patients are getting admitted with cardiovascular disease, hyperglycemia crisis, or hypoglycemia crisis. And they found around 1.7 million among hospitalized patients are getting admitted with cardiovascular disease, around 200,000 with hyperglycemia, and 75,000 with hypoglycemia crisis. So what are the challenges when someone gets admitted to the hospital? There are 3 challenges which we just mentioned. Number 1, the hyperglycemia. We're not looking for prevention of long-term hyperglycemia, hypoglycemia, and the glucose variability within the hospital. And evidence shows that if we identified and we carefully manage those people with this glycemia during hospitalization, it has a direct and immediate benefit on their outcomes. So what are the steps? So the steps are, we have to identify and treat any hyperglycemia prior to any elective procedure. We have to have a dedicated inpatient diabetes management service applying validated standards of care. So we have to be aware of the standards of care. And we have to have a proactive transition plan for outpatient diabetes care with timely pre-arranged appointments. What usually happens is we get patients in the hospital, we manage them, we get them controlled, but upon discharge, most of the patients get lost because there is no a proactive plan, discharge plan. So these steps can improve the outcomes, it can shorten the hospital stay, and it can reduce the need for readmission and emergency department visits. So what does the guideline? Now I'm going to mix my perspective with the guidelines. So the guideline says, when caring for hospitalized people with diabetes, whether it's existing or newly diagnosed, or with stress hyperglycemia, we should consult a specialized diabetes team or glucose management team when accessible. So this is the first sentence in the guideline. And it says that that was recommended by the ADA 2025 for a reason, that having that team may reduce the length of stay and it can improve glycemic and other clinical outcomes. In addition, the 30-day readmission and the cost will be saved. So now what's the role of the diabetes educator? Diabetes educator within the hospital or specialized nurses within the hospital, they act as content experts. So any other nurse within the hospital can refer back to them for management of diabetes. They're supposed to lead and support the quality improvement initiatives related to diabetes outcomes. And they are supposed to identify and mitigate patient safety issues. Specifically, when we talk about hypoglycemia, it's very frequent in the hospital, not very much addressed. They should develop clinical tools and decision support for evidence-based diabetes care, and they should engage in hospital decision-making to improve diabetes care protocols. Now, let's start with education. The diabetes specialized nurse, the main role is education, which is supposed to start as early as possible, and it should start with assessing the needs of the patients. It has to be person-centered education, and they are also supposed to be involved not only in patient education, but team education and documentation and follow-up. If we talk about early learning need assessment, the guidelines here, this is the other box, I just summarized it from the guidelines. It says it should be assessed on admission. It should be provided, especially if a new treatment plan is considered, and it should include knowledge and survival skills. Survival skills are basically, we talk about glucose monitoring, meal planning, recognizing hypoglycemia, recognizing hyperglycemia, and how to deal with it. And they are supposed, as I said, to be involved in team education and documentation of planning and follow-up. An important state in the in-hospital management, it says that all institutions should have validated protocols, and it should be system generated. It's not supposed to be like each and every physician or diabetes specialized nurse should come and write it. It shouldn't be written. It should be part of the system. All diabetes in hospital protocols should be part of the electronic medical system. So the second role of diabetes specialized nurse is glycemic management and targets. And if we look at the ADA recommendations, they do recommend blood glucose level between 140 and 180. And it has to be tighter in a selected group of patients. We can go to 110 to 140, but the general rule is 140 to 180, and in ICU 110 to 180. Medications also is the part of the role of diabetes specialized nurses, as well as hyperglycemia prevention and hypoglycemia prevention and management. And I'll just stop here for the glycemic targets, just a review of from where we got this. The first study done by Vandenberg, and she evaluated the first study I showed earlier, demonstrated that intensive intravenous insulin protocol in ICU setting, keeping a blood glucose between 80 to 110 reduced mortality by 40% compared to the standard approach, 180 to 215. But that was followed later by other studies, the NICE sugar and a couple of meta-analyses that found that going for a blood glucose between 80 to 110 is associated with increased hypoglycemia and increased mortality. Basically, they have deduced from these studies that a blood glucose, a fasting blood glucose of less than 100 is a predictor of hypoglycemia the next day. So if you're having a patient with a fasting blood glucose less than 100, it's very likely that tomorrow he's going to develop hypoglycemia. So all the guidelines has went for 110 to 180. So we have within the hospital to make sure that, yes, the blood sugar should be within this target, and it would have been much better if we could use the sensors in hospitals so we can maintain the target and prevent the glucose excursions. So here comes the monitoring. Monitoring should be done, and the use of technology. We should use POCT as a standard for evaluation of diabetes within the hospital, but if a patient had his own CGM or freestyle Libre, we should use it as well as in the in-hospital management. How frequent should we do the POCT? For those who are eating, it has to be done before meals. Those who are not eating regularly, it can be done every 4 to 6 hours, and those on infusion should be done every 30 to 2 hours. And CGM, as I mentioned, this is exactly the statement of the guidelines that in people with diabetes using personal continuous glucose monitors, the use of CGM should be continued during hospitalization if clinically appropriate, with confirmatory point-of-care testing as well, and if the resources are available and according to the institutional protocol. Hypoglycemia, very important. We should avoid hypoglycemia in the in-hospital setting, and hospitals have to have their own protocols for hypoglycemia management, and that's, again, the role of diabetes specialized nurses. What are the additional role expectations from diabetes specialized nurses? I believe, and I think people who practice in UK, they know that diabetes educators have their own nurse-led clinics where they see patients with diabetes and they do adjust the treatment. And this is basically a role that is not yet applied here in UAE. But they have to be authorized to initiate, adjust, and discontinue medications, including insulin and oral hypoglycemic agents. The evidence shows that diabetes-led clinics, nurse-led clinics can provide education, monitoring, and medication management, complementing the physician's role. And it has improved, basically, and I will show you evidence that it has improved diabetes outcomes. And if you look here, this is the evidence. The impact of nurse-led clinics has been associated with around 1.2% reduction in A1C, as well as 15% improvement in blood pressure control, as well as 30% medication error reduction. So this is something, I guess, it's important, and we have to have legislations within UAE to allow diabetes specialized nurses to have their own clinics. What are the other expected roles? They have to play as a quality improvement leaders. And these initiatives should focus on diabetes care management within the hospital, and they have to work on themselves and their colleagues to have a professional growth and certification. And this is very important. So what are the challenges that would probably face you here? Number one, the lack of recognition. Despite your critical role, I believe diabetes specialized nurses are not very well recognized, and their role is not very much recognized. And the second is training and education. You should, or the whole institution should work very hard on providing training and education for diabetes specialized nurses, and we should have the legal and regulatory restrictions removed to allow you to have your nurse-led clinics. And my final slide is my opinion on the role of diabetes specialized nurses is that they are role models for change, they are educators, they are motivators, they are caregivers, and they are team leaders and collaborators. Thank you very much.
Thank you, Dr. Ala, for an excellent talk. I particularly liked your last slide which tells the truth. Any questions, please, for Dr. Ala?
Thank you so much for that talk. I just want to ask, and I think I totally agree with you that, diabetes educators and specialized educators are crucial and that their credentials are important, and I think that's becoming the case with courses like the Imperial College offering courses for diabetes educators to become certified. But I wanted to ask, what do you think of the role of a nurse practitioner? Do you think nurse practitioners could be a new role or something recognized in this region? Because in the UK, in Australia, and other parts of the world, nurse practitioners can prescribe, they can prescribe metformin, they can initiate insulin. Do you see that model working in the UAE?
That's basically what I was aiming for. I mean, the prevalence of diabetes is huge. Having 100,000 endocrinologists is not going to solve the problem. We would need a collaboration with diabetes specialized nurses, practitioners, as well as endocrinologists, and even internists with interest in diabetes to work together to try to cover and reduce the impact of diabetes on our population.
Thank you. What do you think of what kind of strategy do you think within a particular setup hospital that, collaboration between the educators and the physicians go beyond the traditional role can work, can help, an initiative or whatever?
I'm not sure about other institutions, but in our hospital, for example, we have a couple of diabetes specialized nurses. However, I believe they're doing a great job, but I believe the communication between us and diabetes educator is not optimal. We should actually work together. We should have more discussions. They are part of the team. Even our morning, handover meetings, they should be part of that meeting. We should discuss which patient in the hospital we should do that. What is missing? We have to do this. We have to work more. It's about communication, I guess, and collaboration between different teams.
Thank you very much.
It gives me a great pleasure to introduce one of not only a highly respected endocrinologist, but also a close friend of mine and colleague. Dr. Rahila, I would like to thank you for your unwavering support behind the scene. You are part of this success. Dr. Rahila is a consultant in diabetes and endocrinology and lecturer at University of Sharjah. Her dedication to education and women's health has always been an inspiration to me personally and professionally. Today, she will discuss with you the vital role of diabetes educator in supporting women with diabetes, specifically pregnancy. Dr. Rahila, floor is yours.
Thank you so much, Zainab, for your kind introduction. I'm going to build on what Dr. Ala said, that we need to work together. And I'm going to explain what is the vital role of all of us is in a multidisciplinary team when we are looking after our patients in pregnancy. So this is the guideline for my talk. So why do we need to talk about it? Because it's so prevalent. And it depends on what criteria you are using. And if you look at literature, it shows us that gestational diabetes alone is somewhere between 8% to 25%. So see such a wide range. And that is because everybody is using different criteria in the region still. If you look at the ADA criteria and you apply it, it will show you somewhere between 11 to 15%. But if you apply the International Diabetes in Pregnancy criteria, it is about 38%. And I think it is still not well recorded here in the region. 1 in 3 women here, they actually have diabetes in pregnancy. So I've just tried and summarized all the criteria that we utilize here in different clinics. The main difference is that majority of us who are coming from Europe, UK, or Australia, we will be using the standard 75 grams of glucose. And then we are checking your blood glucose fasting 1 hour and 2 hours. And at 2 hours, if it is less, it is more than 140, or fasting, it is less than, more than 95, then we label you as diabetes in pregnancy. But I think there's a lot more to it, especially in this region, because our risk is very high. If you look at the American College of Gynecologists, what they use is, they will do a 2-step system. So you do 50 grams of glucose first, and then if it is negative, then you're okay. But then if that is abnormal, then they will move on to 100 grams of glucose. So what is different about diabetes in pregnancy, really? You're looking after both the mom and the baby. There is adverse risk of pregnancy outcomes. You always ask women to actually check their blood sugars 4 times a day if you're using the standard capillary blood glucose monitors. We always want them to have a tighter glycemic control. There is increased risk of hypoglycemia for the mother, ketosis, and if they are on insulin, either because of pre-existing type 1 diabetes or pre-existing type 2 diabetes, or even in pregnancy, there is different insulin requirements based on which week gestation they are in. Then, what is the risk of diabetes in pregnancy for the baby? So initially, there's increased risk of miscarriage. The babies can grow either very big, and the reason for that is because as the baby grows, the placenta is producing certain hormones like placental lactogen, the growth hormone, which can cause macrosomia. But on the other hand, if it affects the blood vessels which are taking nutrients to the baby, you can actually see intrauterine growth restriction as well. So you see both extremes. And then it can lead on to polyhydramnios or oligohydramnios. So the amniotic fluid around the baby can either grow more or it can be smaller as well. It does increase the risk of blood pressure in pregnancy or preeclampsia, and later, if we wait for them to deliver at 40 weeks or beyond, then the risk of stillbirth is there. So I like this Pedersen hypothesis. So if you go, blood sugars in moms is high, and that's what I try and explain to mothers. So it will lead to neonatal hyperglycemia. So the babies, they start producing more insulin. What that will do is that will increase the risk of babies having hypoglycemia after they have born. Or if the oxygen levels are affected in the babies, it can lead to intrauterine death. Or overgrowth of the insulin-sensitive tissues can lead to large for gestational age babies. So in women, even before preconception, especially in women who have type 1 and type 2 diabetes, is essential that they see the diabetes specialist nurses, because you are a crucial part of that chain. So any woman of reproductive age group who comes and sees you, it's essential we teach them preconception, what is the targets we are looking for during pregnancy, why, what is the reason, and if that education is given to the mother beforehand, it makes them better prepared for their pregnancy. So we advise women with diabetes planning for the pregnancy, teaching them about the sick day rules, the ketone testing, hypoglycemia, how to avoid it. And I like this because this is recent, but even if you look at it, we have started using the technology in pregnancy, and I think it's a game changer because it gives you so much more information and it makes life so much easier, both for the mother and for the educator as well. But if you look at the slide, the time in range is well defined for women who have type 2 diabetes in pregnancy or pre-existing type 1 diabetes, but still we don't have the standards for gestational diabetes, although the consensus is we should aim for 90% time in range. So once you have made the diagnosis, what treatment options do you have? So metformin is considered safe. If you look at the American guidelines, they will actually say you can use the glyburide or glibenclamide. Then you can use short-acting insulin with meals or long-acting insulins with the once a day as a basal. Or in type 1 diabetes, you might need to consider insulin pumps even in pregnancy to get better control before or during the first trimester as well. So what are the recommendations for the treatment of GDM? Again, the main difference is if you look up at the NICE guidance or the European guidelines, yes, you can use the glucophage, completely safe in pregnancy, but if you look at the American guidance, the ACOG and the ADA will advocate insulin for the use in pregnancy. Now, over the next couple of minutes, I'm going to take you through some of my cases. There's no right or wrong answer, but it is just to highlight how to work in a multidisciplinary team. One person cannot do it all. As a physician, I can tell the patient what the diagnosis is, start them on the treatments, but I just wanted to highlight with these cases what is the role of the dietitian, of the diabetes specialist nurse, and how it can change your management, taking the woman through the journey of their pregnancy. So the first case is 37 years old. She presented to me at 27 weeks gestation. This is her third pregnancy. She has 2 other children, less than 5 years of age. This was unplanned pregnancy. She had gestational diabetes in the first pregnancy, treated with glucophage. Okay. So she had another glucose tolerance test done at 27 weeks gestation. Anybody disagrees that she has gestational diabetes? So everybody agrees that she has gestational diabetes, correct? Okay. So I agree. We said she has gestational diabetes, so I gave her CGMS. Anybody wants to comment on it? Yes, Shiju.
Here the glucose target is between 70 to 180. For the pregnancy, we need to tighten the target.
Good. Well done, Shiju. Yes. So that is one thing. Can you change it then? On the Freestyle Libre. Educate me now.
Snapshot, yes.
Yes.
We can't change in the AGP, but
True.
we can change in the
Yes.
snapshot.
So good. Anything else? Sorry? Yes, it's only 46%, yeah? So she's not utilizing it that well. Anyone, anything else? Okay, let's see what happens with her, yes? So I agree with all that. So this is the snapshot that you asked for. So if I go back for everyone, here you look, it's 97%. But remember, we said tight glycemic control, so that's between 70 to 140 for pregnancy. So that's why the snapshot helps you better than that picture. Anybody has any comments now? Yes, please. Good. Why?
Because in pregnancy, hypoglycemia is start below 60.
Yes. So can you change it on the settings?
Sorry?
Can you change it on the settings?
Yes.
Good. Well done. Yes. So this is just to elaborate that you know how we can change. Normally we say 70. Less than 70 is your hypoglycemia. Not in pregnancy. In pregnancy, 63, less than that, or even 60, we will count as stage 1. Yes, that's where we need to. Otherwise, what happens? Especially on the CGMS. I'll show it to you. Yes? I think it's in the next case, but I'll show it to you. Yes. Here. So it's a daily graphs now. Yes? So I'm trying to put through. So we looked at the snapshot. We identified a problem. Anybody can identify any problems on this one? Anyone? Yes, connectivity. Yes, connectivity. So if you look at it, there's a lot of connection problem here. Yes? So what that means, it's again going back to the patient, explaining to them that, you know, either their phone has been away from them. Remember, she has got already 2 young children. Yeah? So all these things matter now, isn't it? Or she has been away from her phone for longer period of time. So just be mindful that that is the reason we cannot see so many readings. Anything else? Yeah. Good. And when do you tell this to the patient? I've learned it after using it to the patient several times. When should we tell the patient? Otherwise, what happens?
We always tell them in the first session.
Good.
Reinforce, reinforce.
Yes, so see, the amount of time that needs to be spent, it's not only about prescribing like we normally do in our clinics as physicians, that we have given the patient the device. What to do with that device is very important. Otherwise, what happens is they are worried, my blood pressure was dropping down and I started eating. That is what normally I see when we haven't explained it to them, especially in pregnancy, and it causes undue stress for the mother. So totally agree with all that. Anything else anybody has picked up? Okay, so I thought she was having some of the post-meal high blood sugars. And then at 30 weeks here, what we did was we introduced the glucophage with the meals. Okay? And that's why it has started settling down, yes? So I'm going to show you a couple of slides and I want people to concentrate and tell me what's going on now. What is the fasting glucose you were aiming for? 95. Is it there? Okay, so that's one thing. Let's see what happens next. So she's only on glucophage, yes? You pointed out rightly, connectivity problem, 46% only usage, yes? So now, at 32 weeks, there are no CGMs reading, okay? And I get a phone call from actually the obstetrician. And she said to me that she could not feel, the patient cannot feel any baby movements at home. I looked into the Libre, I said there are no readings. So the patient actually went into the hospital. And now there is intrauterine growth restriction on the scan. What would you do next? What do you think should be done? Anyone? Yes, please. It's okay. There's no right or wrong answer. I'm telling you honestly. That's why I'm just trying to take through the case. Yes. Good. Yes, I did. Yes. So if there is IUGR, we should not be using the metformin. That's the first thing I did. I stopped that. And then she was started on insulin. In the hospital, her blood sugars were high. So her fasting and post-meal blood sugars, so post-meal were about 180, and her fasting glucose were high. Now let's go through the next. So she was started on 10 units once a day at night and 4 units with her meals. This is at 33 weeks. So you have seen what was happening in the beginning, yes? 27 to 29 weeks, she's fine. And now this is happening. Anything else I need to do? Good. Yes, so that I did. What else? Yes, baby's movements are fine now. So there was actually nothing else with the... Okay, why did you say that?
Because sometimes sensor can be failure.
Yes. True, yes. So normally I find in pregnancy, at night time, because patient is sleeping on that side, that is a simple reason why they will get hypos at night. But here also she's getting it during the daytime. And I had told her to confirm it with the capillary blood glucose. This is what keeps on going. So now she's 35 weeks, and I think I have one now. I have this one, last one, yes? What else? Okay. You're saying all the things that I was doing, yes?
Because disconnected, and she might say, no, I was checking, but it was not showing, especially with the new update. So,
Anyone wants to ask anything else? Sorry? Good, she was. Low carb, okay, what else? Yes, she had started doing that. But there was a reason. The reason was, okay, so it always goes back to the history. I was so focused on this and her pregnancy, I didn't look into the other factors. Remember, she had a young family, okay? And it was difficult to take care of. All of these things, if I go back, yes, I had started her insulin. She was quite good otherwise. During early pregnancy, no problems, used to come with her husband. And then when this happened, the scare they had when they went into the hospital, the problem was she was going through psychologically trauma in the sense that not able to look after her 2 children. Then she was just eating. Husband came in and said she does not eat at all. It is low carb diet. Then there were a lot of psychological issues. So she was actually seen regularly by the diabetes specialist nurse and by the dietitian. And the reason for that was her mother could not come in for her delivery. So it was a lot of mental things that was going on. Then she was not able to sleep at night. So I thought that was at night time. It was actually she was awake at that time. So all she was doing was, in between, if you look up, on the 21st of April, she's just having grazing through the day. So we did reduce the dose of insulin, but it was just actually giving her that support. So asked the obstetrician, she was seen by the psychologist, and that's what made the change for her. And we did reduce the insulin, like I said, and she delivered at 36 weeks. There was no IUGR at the moment. Now she had a healthy baby. So the purpose was that, gestational diabetes, it takes a lot of us. So if we are all seeing the patient at different times, we do miss things. And as a physician, we were just titrating her insulin, bringing it down, increasing it. Look at the other factors. Why had she changed her eating habits? Why she was sometimes eating very high carbs, and sometimes she was just going down because she had stopped eating completely. Once those were addressed, she actually became fine. Let's take you to the second case, and I've got last 30 seconds, but I'll take you through the case. This was her first pregnancy, 28 weeks pregnant, twin pregnancy. We all agree she had gestational diabetes, so her 1 hour is high as well as her 2 hours. She started doing the home blood glucose monitoring. What do you think is wrong here? Fasting glucose. So the ADA guidelines are, as well as the NICE guidelines are, if you have fasting glucose high, we start them on insulin. So this is what was done. Again, here there's a problem with connectivity. But if you look at it, she required only 4 units of Tresiba, and her fasting glucose along with the post-meal glucose all settled down. So she delivered naturally and had a normal baby. Third case, 50 years old. She was a marathon runner, triathlon runner. Came to the clinic, first pregnancy, 20 weeks gestation, no family history of diabetes. Look at her 1 hour. She was literally very slim. BMI was about 20. And look at her CGMS now. She's still running at 25 weeks actually, because this is her baseline activity level. So look at, she's getting both the fasting and the post-meal hyperglycemia. So she was started on basal bolus insulin, and then she was very good at documenting what she was doing. I do not find many people, especially in pregnancy, who do that. But she was like, why did I develop it? There was no family history. So this was a tool for her. She wanted to change her behavior, tried using it for that, explained to her that no, it is because of pregnancy, that's why pregnancy hormones are doing that. But she required both basal and bolus insulin, made changes to her diet, was seen regularly by the dietitian for the titration of her insulin, ended up with 30 units of Tresiba at once a day, along with the high dose with her breakfast, although she used to have just a tiny amount of coffee, but that's where she will get the peak. Delivered at 30 weeks, had premature rupture of membranes, emergency C-section, but both mother and baby did well. And 6 weeks after her delivery, blood sugars were completely normal. I'm going to stop here, and these are my references. Thank you.
Thank you, Dr. Rahila, for the amazing presentation. Anyone from the audience has a question? I think it was an interactive session. So crystal clear, right? I have one question. Pregnancy by itself is a burden, and having diabetes along with it would increase the burden. So what strategy would you use to empower the pregnant lady with diabetes to take charge of her diabetes confidently?
I think that's where the key role is of the diabetes specialist nurses. I think once the diagnosis is made, this should be seen both by the diabetes specialist nurse and by the physician only. So actually on the first session, you're giving them all the advice and empowering them. The thing is, you always need to remember it's a very short period of time that you have with pregnancy. It's not like you have the luxury of time that you might have with another patient with type 2 or type 1 diabetes. If you do that explanation well, empower the patient and also with the dietitian, then I find with these tools, you actually don't require many times treatments because they do change their behavior once they understand and the stress is not there. Otherwise, they will go to Dr. Google, do it, and then they will say, oh, we have stopped taking all the carbohydrates. That's the first thing otherwise you see. Yes?
Thank you so much. Now, to conclude this session, it is my pleasure to introduce Dr. Mohammed Al-Khatib. Dr. Mohammed is an internist and endocrinologist at Health Plus Diabetes and Endocrinology Center at Abu Dhabi. He will highlight the diabetes educator essential role in obesity management and lifestyle intervention. Dr. Mohammed, thank you.
Yes, thank you very much. Assalamu alaikum and good morning, everyone. I'm happy to be here today, and it's my honor to be invited by diabetes educators to give a talk. And I would go more than Dr. Bashir said before. An educator is not doing just a job as an educator or diabetes specialist nurse. I see them in our clinic, and we physicians have to be honest. We don't have the time to explain all of that, and we don't get the truth out of our patients if we do the job alone. So for me, a diabetes educator is not only an educator. I think they do the job as a diabetologist, they do the jobs as psychologists, and furthermore, they do the job for us and for the patients, not only as a colleague, but as a friend. And I think in this relationship, we have to see the role of the educators completely different. We don't take the time, and I'm honest, I don't have the time to ask a patient about skipped meals, skipped injections, secret eating. So that's all things that they slip from our clinics. And we adjust our medication, we adjust our technology, we improve our treatments, but the core thing is we need to talk to the patient. That's a very aggressive treatment. Talking to the patient is very aggressive. And we have to start there before we go. And when I was asked about the talk management of obesity, I didn't want to make it very scientific and talk about medication and all the approaches that we have to support weight loss for our patients. I think it's more of how do we motivate them to lose weight and maintain the weight loss, because we are talking about a problem that is not only locally, it is a global burden and it's everywhere. And if we look at the numbers, that is just the recent data that we're expecting. How many people will live with obesity, with or without diabetes? It is a challenge for all of us. And that's where we need the support, not only diabetes educators, we need the support of the whole multidisciplinary team to tackle and target obesity. And the first step was, if you look at the recent recognition of obesity as a disease, that's the first step that we can move forward to start treating obesity in diabetes, but also without diabetes. And that is just to show you the obesity rates in the US. It's scary. And looking at Europe, it looks a little bit brighter and better. But if we look now at the childhood obesity, and that is our future, these are the kids in our future. And this, I'm looking here just the global prevalence, and then look at our area where we are, the MENA region. We are in extremely high rates of obesity in our children. And I think that is a group of patients that will form our future. And just imagine, we do not support them now, how the rate of diabetes and all other complications of obesity will increase. And the definition, I don't have to give you a definition of obesity. I think it's very clear. Just the recognition of itself as a chronic disease will help us in future to tackle it. So many of the US, but also global societies now acknowledge and accept and recognize obesity as a chronic disease. What is the definition? And we always follow the BMI, which is not always accurate to define obesity. There are more and more criteria now coming, not only the waist circumference, we have the hip to waist ratios, we have the hip to height ratios. So many criteria and factors that you can use now to define obesity and give a staging of obesity. And if we look at the etiology, and that's what we always thought, it's whatever you eat, the energy intake, and whatever you burn, the expenditure, that will cause obesity or you will lose weight. But is it that easy? It's not. It's not, because we have a lot of other tissues that play a role. It's not that just what we eat or what we do in our exercise to reduce or increase our expenditure of energy. We have the adipose tissue, pancreas, the gut. We have the genetics, we have medications, we have the environment. So a lot of other factors that we can influence, but factors that we cannot influence, that increase the weight and obesity. So the hedonic input for our patients with obesity, and if you look at yourself, if you're obese or not, you have the same problems. This is that you're not controlling everything when it comes to food. And there are two parts, and I will make it simple because it's really complicated. So the eating for hunger, this is the normal physiological, when you have it, you are hungry, you go and eat because you're hungry. And then there's the other one, this is the eating for pleasure. And we discussed it yesterday. Eating for pleasure is not that easy to control, because when you're happy, you eat. When you're angry, you eat. When you're mad, you eat. When you're sad, you eat. When you're depressed, you eat. The children dwell in school. We gave him food. We give him chocolate. You help the patient. He brings you a big box of Patchy chocolate. So everything goes, and this goes into the eating for pleasure. This is not, I'm not hungry for chocolate, but I still get it. And you go to a buffet. You might be hungry, you eat a little bit, but you still go for the second course or the third course. Or what about the sweets and the fruits? I'm looking at my colleague here. we were looking, we wanted to stop at the third round, but then there was a fourth one, and there was the fruits, and then it looks yummy. So we go for it. So this is the eating for pleasure. We have to control, or try to control that. But can we as a physicians do that? No, we can't. We need these motivators. We need someone who sits with the patient and understands all these. Because these two decide if we eat or not eat. And that's how it looks. That is, when you look at it, don't be scared, so I'm not going to explain that. I want you just to know it's complicated. It's not easy to say, now, stop eating or tell our patients, you have to go on a diet. So it is a complex disease, we agree on that. And we have the two parts that work against each other. The one is the hypothalamic hunger system, and the other one is the rewarding system. And unfortunately, the rewarding system can overrule the hunger system. So we eat, even we are not hungry and we don't need to eat, but we still eat because of this mesolimbic rewarding system. So understanding this might help us to go to our patients with an individualized plan, if it's lifestyle, if it's the mesolimbic system that we can tackle, or if really these patients would all benefit from a medication that will suppress appetite or increase the energy expenditure. And if we look at that again, what I showed you, the energy intake and the expenditure, you will see that whenever we start dieting, we lose weight, and then our hunger increases and the desire to eat increases. So we restrict the hormones of satiety to the downward, leptin is lower, and then we start conserving our energy, the hunger increases, and then we regain the weight. So that is the challenge. I can lose weight. Every one of us can lose weight. But can we maintain this weight loss? That is the challenge. And obesity is contributing to many complications. We have seen this slide many times. So it's not only that is my fat. I'm targeting all my organs, and I have complications of all the organs. And I like this slide because it gives you a little bit of definition of how obesity raises, develops from the genetics, epigenetics, the so-called obesogenic environment. I call it like that. I like this terminology. And then the complications. Once you end up with diabetes, then you have obesity and diabetes. We call it diabesity. So this is a very complicated and very low steps can help us reduce these complications of obesity. It's not only type 2 diabetes, also the mortality can be improved, lipids, hypertension, but also sleep apnea and all health-related outcomes. So how do we approach, and this is the 5 A's approach for obesity management. I will just go very briefly on it. So this is, you have to ask the patient, and then it starts. It's very aggressive. You have to talk to the patient. Yeah, that is the first step for us all. Then assess the patient. What is his story, the history? What is the reason? What could be the best treatment for him for his obesity? And then give him the treatment options that we have. Agree on goals, but goals that we can achieve, not goals that are somewhere utopic. And then follow up and reassess. So the recognition of obesity as a chronic disease is a start off. And then you discuss with the patient. Don't expect all patients want to lose weight. That's what we assume. If someone comes with obesity, that they want to lose weight. No, it's not always the case. So you have to talk about it. The patient is not ready. Maybe he doesn't want to change. So these are the things. You have to ask the patient if he's willing to change. Then assess. Assess means not only looking at the BMI. We have to take the whole comprehensive story. Look at other measurements like blood pressure, A1C, lipid profile. And then you have the Edmonton obesity staging scale. So if you look at it, that gives you a better or clearer picture of the complications of the patients. You can have a low stage, stage 0, where there's no complications, no risk, no symptoms, no limitations, up to the stage 4, where you have severe complications, severe symptoms, and limitations with obesity. So discussion of treatment should always, and that is where the educators play the biggest role for us, together with the dietitian, medical nutrition therapy, and physical activity, before we go to the next step of pharmacotherapy, surgery, and the psychology. So offer these pillars to the patient, and then he shows you here what are the medical nutrition therapy that is suitable for our patients, and what is the physical activity grade that patients can tolerate, and then go into detail with them, into psychological intervention, pharmacotherapy, or then if everything fails, then you discuss bariatric surgery. So what can lifestyle intervention do? And it can. You can reach weight loss 5 to 10% only with weight loss. And the maintenance, you see, if you maintain it over 4 years or 8 years, if the intensive treatment and education, but as well as the follow-ups, where people are guiding you, and that is the role of our supportive educators, that we tell them, we guide them through the years so that they don't regain their weight. So this is weight loss just with lifestyle intervention. Pharmacotherapy, and that is the easiest way for the patients to come to the clinic, and they target it already. They don't want to hear anything else. They come to you in the clinic and say, okay, I'm here, I want Mounjaro. Full stop. So they don't even negotiate with you. So I'm here that you prescribe me Mounjaro. And then you start, and that is where you have to take the patient out of this idea that Mounjaro is not the solution for everything. And if you see here, we have different medication that can support you. And I'm not focusing my talk today on medication. Yeah, I will just show you that you have an idea what kind of medication do we have when you talk about the patient, and the patient will confront you when they go to the educators. They will tell them, what do you think about Mounjaro? What do you think about Wegovy? What do you think about Saxenda? I hear there's a new drug from America. It's a wonder pill. It will make you burn your fats. Then there's the Green 7, and then there's the BCA, and then so a lot of things that you hear from the patients, you have to know how to reply to them, how to answer their needs. And that one size or one pill fits all, that doesn't exist. There is nothing that you say, this is a wonder thing, and then I give it to everyone, and everyone will lose weight. Me in the clinic, I see patients that are on the highest dose of tirzepatide, they don't lose weight. They're on the highest dose of semaglutide, they don't lose weight. And I have patients that are on the lowest dose of a pill, and they lose weight. So it's completely individualized treatment for the patient. So I will go you just through the slides, just look at them, take the numbers. So like Contrave is a weight loss medication, oral, that you start with low dose, 1 tablet a day, and then you slightly increase it weekly until you reach the maximum of 4 pills a day. The weight loss average is 6 to 8%. Xumia is now here in the UAE, the new kid on the block. In US, it's there since the last 8 years. So it can achieve a weight loss of about 10 to 12%, which is a good weight loss. But we are laughing about it because we are used to numbers of 20 and 22 and 25% from the injections. Yeah, but it is a good weight loss drug. So, and it is oral, it is a pill. It's not that you have to inject yourself, and it has not the severe side effects that we used from the injections. So this is a good option for our patients that do not want to go for injections. Then liraglutide, everybody knows you. It was for diabetes patient named Victoza. For the weight loss, it was named Saxenda. It goes up to the dose of 3.0. And you see a weight loss of 8 to 11% with the daily injections. Why is that a good option? Because we don't have many drugs for our young patients, for children, adolescents with obesity. It was approved for this young patient. It's still approved. Unfortunately, it's now out of stock, but this is still approved for our patients, young patients that need support to lose weight. Semaglutide, this one is approved for patients 12 years and older, so we can give it to our young patients. A weight loss of 15%. And that is now the numbers where we say, wow, this is something I can give to my patients, very easy. But always be aware, without the lifestyle intervention, without keeping a healthy lifestyle, all that weight loss will regain if they don't stay on this medication. Yeah, so Wegovy or semaglutide is a good drug for weight loss. Mounjaro, we talked about it, everybody's talking, tirzepatide, we can reach a weight loss 20 to 22%. So it is a very effective drug to give a big push for the patients where they can have a good body weight loss within the first 6 months. And you see it, the weight loss starts immediately after the first 2 injections. So that's a summary of all pharmacotherapy. You see all the drugs help, whatever you use. We can lose weight between 5 to maximum 20 to 25%. So whatever drug you use, whatever is individual, the best for your patients. How do you select it? And that is where the educators, the dietitian, the psychologist, the physician, and the patient come into the game. We look at the efficacy, of course. We look at comorbidities. Then we look at the safety. Then the mode of action, is it an oral, is it an injection? We ask the patient what do they prefer, and we look at the costs. So that is, on the left side, you see what we have currently, and on the right side, you see what's coming. Yeah, and you see the right side is, I don't know if it should have more hope in the drugs, or should it be scary that the pharmaceutical industry is going more into obesity. That means our obesity rates will increase dramatically. So we are getting a lot of drugs that will be soon approved for weight loss. So the last 5 minutes, I will focus just on what the educators do to make our life and our job easier. This is the comprehensive lifestyle intervention. It is not only about calorie intake, it is about the physical activity, but mainly the behavioral modification of patients, how to understand. We should understand it, the physicians need to understand, and then the patients need to understand the factors that are associated with obesity. And then, from our side, we need to understand, not only for our patients, even if you run on the street, if you run in the malls, we need to understand the stigma that is associated with obesity or weight increase, and all that together can help you to a comprehensive lifestyle intervention. Use people-first language. We don't talk about diabetics. We don't talk about obesity. We don't talk about any patient that, according to the disease, it's not blind. It's a patient with a vision or impaired vision. It's a patient with diabetes. It's a patient with a higher BMI. So this is the language that we should use. We should use weight, high BMI. We should avoid fat, obese, morbidly fat, morbidly obese. And the stigma that we always think, and then if you go into yourself, you'll catch yourself, you did it as well. They are lazy. They're not successful. They don't have motivation. They will, they don't want to, they're not consequent. They're non-compliant. You'll catch yourself in the clinics seeing that maybe you are tired, maybe the patient is not in the mood, and you'll catch yourself in that situation. We should avoid it. So this is not healthy for a motivational treatment for our patients. So how do we engage these patients to be more active in their lifestyle interventions? So we have to ask them, are they ready to feel, or do they feel that they want to change? Do they want to change the lifestyle behavior? Or ask them, is the current weight affecting your life? And most of them will say yes, but you have to ask them. Or what kind of things have you tried in the past? What was helpful? What was successful in the past? Which therapy helped you lose weight? Ask them, do you feel that your health could be better or different from now? And then ask them about the steps that they are willing to go. Do they want to go big steps or do just slow steps? So the shared decision making, we have to use the motivational language, the techniques to engage our patients. We have to discuss the goals, smart goals, goals that you are happy with but the patient can achieve. Does not help him to tell him you have to lose 10 kilos in the next 2 months. He might not do it, and then he will not come back to your clinic because he didn't reach his goal. So use smart goals. Use the lifestyle intervention plan with him comprehensive, that you discuss all the factors. Then consider the therapeutic agent that is the best for this treatment for this patient. So individual, not every drug fits him. And then discuss alternative treatment of the other drugs. Maybe they're using medication, like from the psychiatrist. This medication might have weight gain, so discuss it with your colleagues. Maybe we can change medications there. And then discuss how you monitor him or how you want to follow the patient. So the main role for me is that the educators, they usually initiate these conversations where we do not go into details. We don't ask about the meals, what is the consistency of the meals, how much carbs, how much fat. That is something, this has to be initiated by the educators. We have to look at the barriers of care. Why are they not compliant? Why is it not working? Then also the education and counseling on the medication, how to use it, when to use it. Recommend not only medication, go for non-pharmaceutical treatment options. And then refer to a multidisciplinary team. It's not only the doctor and the dietitian. It is the psychologist, it is the orthopedics, it is the, many other people are in this team. Use these sources. And then promote the self-efficacy of the patients. I have this final slide. This is the last ADA-ESD consensus. You've seen that. I chose only this slide because it gives you a summary of everything that's related to diabetes and obesity, and it shows you all factors that are important. First, it starts people who benefit. Again, people first language. People who benefit, that's all patients with diabetes, all patients with obesity. And then you can see the advantages when you look at positive health behaviors, well-being to improve the health outcome. And with that, please look at that because it gives you stepwise, it gives you the language and helps you. So with that, I would say thank you and healthy lifestyle for us all. Thank you.
Thank you very much, Dr. Mohammed, for an excellent review. Any questions, please, Dr. Mohammed?
Yesterday we had a research presenter who presented a talk about using GLP-1 in type 1 diabetes. So still, we don't have data on this, but from your experience, do you support this?
This is a tricky question. Yeah. Legally, I would say I can't answer that. Yeah. Unofficially, I will answer you, yeah, I'm doing that as an off-label treatment within my clinic. I'm doing it myself. Fortunately, we have data, we have safety data, and there are ongoing trials. The liraglutide trial, for example, it is already published. It is safe to use liraglutide in type 1 diabetes patients, yeah, and it would benefit with the patients who have insulin resistance in type 1 or obese. Yes, we do it. We use GLP-1 in type 1 with insulin resistance, with obesity. I'll do it in my clinic as an off-label, but I inform the patient that is an off-label treatment, and I inform my team that is an off-label treatment, but it is a good tool. We're still waiting for the data to be published, but it looks promising.
Any further questions? Yes, please.
Assalamu alaikum. Thank you very much for the informative lecture. My school, I'm a school nurse. So my question is, in school health in Abu Dhabi Emirates, we annually screen the students. So severely obese and overweight students are referred to the dietitian yearly basis. Severe obese students are followed up 3 times a year, and the compliance with the parents who follow up is like 2%, 3% who keep following with the dietitian. We have programs to monitor the canteens, so there are restrictions on the canteens' quality of food that been provided for them. Also, there are sessions in PE specialized for them, in PE sessions, but still the results are not satisfying for us. Is there any initiatives or plans that have been done in other countries and showed improvement for reducing obesity in schools, especially in the teenagers and adolescents age? Thank you.
Yes, this is very political to start any initiative. Yeah, initiatives are always difficult to implement. There are initiatives that we want to do on for example, in Abu Dhabi, where we use this obesity days, we use diabetes days to start initiatives, to have measurements, to have then educational and supportive teams that contact the people. Initiatives, I know it from Europe. In Europe, it's much easier. We have so-called camps where these patients or the children and the parents are invited to stay there for 2 weeks, for 3 weeks or 4 weeks, and they get the whole treatment, including medical nutrition therapy, but also all advice and education and the follow-up tools where we can, after the camps, still follow up with them. And they come annually to these camps to stay there, and they are very effective. I think such kind of initiatives would help the children to reduce obesity rates.
Yes.
For newly diagnosed obese patient, what are the laboratories that you could include on the initial visit?
What are the targets?
No, what are the laboratory reports that laboratory tests that you will be requiring for the patient?
So the BMI targets,
I mean, other than the lipid profile and
Yes, so if
glucose
they have the initial and you are diagnosed with obesity, first of all, we define the grade of obesity by the scales that I showed you. You can use BMI, you can use waist circumference, or you can use the Edmonton scale. So the targets for that is we have to be as close as possible to the normal weight. But the lipid profile, for example, as you mentioned it, patients with obesity or overweight with other risk factors like hyperlipidemia, like hypertension, or prediabetes, the targets are very strict for us, where we lower the BMI. Even overweight patient, we would tell them, yes, you need to have any intervention done.
Yeah, thank you so much,
Thank
Dr. Khatib. Thank you to all the speakers. It was an exceptional session. Thank you so much.
Bismillah ar-Rahman ar-Rahim. Good morning, distinguished guests, respected colleagues, and dear friends. Yesterday, we got the opening of the First Diabetes Educator Society Conference, and we would like to share with you a short clip for yesterday's recap. Yesterday, our President, Ms. Zainab Al-Abadla, shared the inspiring story of how this journey began, a story born from a simple yet powerful moment in her clinical practice. She once cared for a young patient who was relocating to Abu Dhabi, and what seemed like a straightforward referral turned into a 2-week struggle to find another diabetes educator to continue the patient's care. That experience shed a light on an important reality: the need for stronger communication and connection among diabetes educators across UAE. Instead of accepting it as a limitation, Zainab turned it into an opportunity to connect, to unify, and to empower. Guided by her determination and fueled by her vision, she gathered a small group of passionate educators who shared the same belief that teamwork and collaboration could elevate diabetes education in our country. From that moment, the Emirates Diabetes Educators Club was born, and what started as a small initiative soon grew into a national movement. With the encouragement and mentorship of Dr. Fathiya Al-Awadi, our trusted guide and supporter, this idea transformed into a structured, purposeful, and compassionate network that continues to thrive today. From those early days, we learned the true meaning of teamwork, educators coming together not just to share knowledge, but to build a family that believes in education, empowerment, and prevention. In just 3 years, we have grown from seven founding members to more than 100 passionate professionals, nurses, dietitians, researchers, and specialists, each contributing their unique expertise to a collective mission. Together, we build a foundation based on collaboration, education, and research. Together, we created programs that changed how diabetes care is delivered, not through competition, but through connection. And in April 2025, our journey reached a defining moment when the Emirates Diabetes Educator Club became the Emirates Diabetes Educator Society, officially recognized under the Emirates Nursing Association. That transformation gave us a voice, a platform, and a national identity that continues to inspire new generation of educators. This conference stands as a proof of what can happen when passion meets purpose. It's more than a scientific meeting, it's a reflection of who we are as educators and advocates. Every session you attend and every discussion you join represents our collective belief that patient education is at the heart of better outcomes. We are here to learn, to share, and to collaborate across disciplines, institutions, and generations. We are here because every person living with diabetes deserves a well-informed, well-supported team beside them, and that begins with us. As a co-chair and on behalf of the organizing committee, I stand before you deeply proud of what we have achieved and excited for what lies ahead. Our promise remains clear: to continue collaborating across the Emirates and beyond, to innovate in patients and professional education, to support every educator, ensuring that no one works in isolation again. We will keep bridging the gap between knowledge and care, between educators and patients, between today's effort and tomorrow's vision. And now, ladies and gentlemen, it's my great honor to welcome our speaker, Dr. Mohammed Al-Hawqani, a distinguished medical professional devoted to advancing medical education and patient care. Dr. Al-Hawqani serves as the Secretary General of the National Institute for Health Specialties, NIHS, where he plays a pivotal role in shaping postgraduate medical education across United Arab Emirates. He is also an associate professor at the College of Medicine and Health Science, UAE University, and a consultant in respiratory and sleep medicine. Please join me in giving a warm welcome to Dr. Mohammed Al-Hawqani.
Assalamu alaikum wa rahmatullah. And some people will say, why someone, a respirologist and sleep physician, come and talk today? Well, I'm wearing my other hat as an educator, as a Secretary General of the NIHS, and I'd like to give you an idea of who we are. So to start with, the National Institute for Health Specialty was established to spearhead, regulate, and organize professional development for the health workforce, with a particular emphasis on specialty training. Our vision is to develop a highly qualified health workforce able to support the health system and promote health and well-being. Our main roles, we set the standards for institution and specialty program. We accredit the training institution and the program. We conduct the specialized examination and issue the certificates, also known as Emirati Board. We also develop and regulate the CBD. These are our strategic dimensions, where governance, training environment, accreditation, and assessment are key pillars. And these are our local partnerships. And as you see, most of them are the regulators in UAE as well as the main health providers. We have started a few years ago and signed a partnership with the Royal College of Canada, the ACGME International, which is the accreditation body in the United States, the Saudi Commission, and the Arab boards. Now, why this is important? Well, we do have an issue in the Middle East and the Mediterranean region, where there is a shortage of almost 2.1 million of the health workforce by 2030. And there's also issues with 20% of the global shortage by that same time. There's imbalanced distribution and increasing international mobility. We're lucky in UAE. If you see the density of health workforce per population, we're doing very well comparing to many other countries in the region. But what about the ratios and the number of physicians per 1,000? We're almost there, meeting the benchmark of 3.1 physician to 1,000 population. What about nursing and midwives? We're not there yet. The benchmark internationally is 9 to 1,000. We are almost 6.3. What about the nurse to physician ratio? It's 2.7, the benchmark, and we are almost 2.1. What does that mean? We need more nurses. And so far, the nursing and midwifery consist of 43% of our health workforce, comparing to the physician who are around 20%. Now, we are 20%, I'm a physician, but we have a very clear career pathway. Students go to a medical school, spend 5 to 6 years, followed by an internship, followed by a residency programs, very well structured, and then a fellowship program. They will be specialists, and in another 2 years, they'll be a consultant. Straightforward. And I said, let me see, what about the nurses? It's really confusing. There's a pathway for master degree, a certificate, a diploma, and it's not clear who's a nurse practitioner and who's a specialist nurse. And we said, okay, well, we've done a great job so far with medical, but what about nurses? We need to scale them up. We need to enhance their competencies. And we need to protect and safeguard the health workforce to ensure their safety and security and well-being. So to simplify it, if I apply what we're doing in medicine, this is how it should be in nursing. A graduate nurse would go to a transition to practice equivalent to an internship to ensuring that she's ready up to hands-on practice, competent, and then she would go to a residency program of maybe 2 years to become a nurse specialist. A nurse specialist could be an pediatrics nurse, it could be in critical care, or it could be in diabetic education. And then she could do more advanced training or a DNB to be a nurse practitioner and start prescription. That would be a nice career path. Would you agree with me? Excellent. And therefore, we said, yes, we should include them. And so far, we do have transition to practice, internship, residencies, fellowship, and clinical certificate. Where we are so far, we have 88 specialty and subspecialty in medicine, in dentistry, in nursing, in clinical pharmacy, as well as the 2 internship, very well known, the medical and dental, and clinical certificate, and the most popular one is the dental implant. Within the nursing, we have so far 7 specialty programs: the transition to practice, mental health, adult critical care, pediatrics, and emergencies. So these 5 have finished their standards. It's available on our website. What's coming next, hopefully by next week, diabetic health nursing, hopefully they will present their requirement to the NIHS, in which, yes, it can be then available for institution to adopt. Okay? We do not run the programs, we set the standards. And then hospitals and institutions can apply for it. We did not stop there. We also worked with Allied Health, because we found many of the graduates of Allied Health are sitting home, especially non-UAE national who required 6 months of internship or transition to practice. So we worked with the physiotherapist, with the anesthesia technologist, with the speech language pathologist, clinical nutrition and dietitian, the medical diagnostic radiographer, and the medical lab science. These are so far the 5 approved requirements which are available. If anyone have interest, they can visit our website. And people are asking me, well, how do you set the standards? Well, we look at what is the best internationally benchmark. And then we contextualize it to our local practice. And then the scientific committee review it. They look at the training part, the curriculum part, and it should be then presented to the Council of Scientific Affairs, which consists of chair of scientific committees, leaders in medical education, before it become approved and available in our websites. I don't need to present this slide because, mashallah, the previous 3 speakers said why diabetic health nurse matters. Why do we need them? And I don't need maybe to go through the role of diabetic nurse specialist, because you know it better than me. But I need to tell you a little bit about the upcoming programs. It will be a hands-on, 24 months training in clinical setting, in which we would like them to go through the competencies which are set there on the standards. The whole competencies related to the body weight management, the diabetes education for both outpatients and inpatients. We do encourage collaborations. Most of our programs are running across more than 1 site. Let me give you an example. When we talk about residency programs, the surgical residency programs in Abu Dhabi, the residents rotate from Tawam hospitals to Sheikh Shakhbout and then to SKMC, and then they come to Dubai. And this is very important clinical experience. But there will be one sponsoring institution who will look after them and sign the training agreement across all the programs. Same idea. We'd like to see fresh registered nurse coming and say, I'll do the transition to practice and the 2 years program to be qualified and competent as a nurse specialist. Unfortunately, Bashir is not here, but she will be a specialist by license. And we're aligning with the health authority. And we don't want to see nursing teaching nursing. We need to see interprofessional education, in which the nursing residents train alongside physician, dietitian, pharmacist, podiatrists, psychologists, and other team members, because this is real life. Our accreditation standards are based on 5 pillars. We need to ensure there is a governance structure in the institutions, in the hospital. There is a designated institution official, a program director with a protected time, faculties who are also dedicated there, a training environments, trainees, bylaws, and policies that protect them, faculty, and ensuring that there's a continuous improvement and innovation. What else we do? We do the assessment parts. We do the examinations. Very popular one is the EMRI, Emirates Medical Residency Entry Examination. For all the graduates of medical schools, they do these exams at the final year of their school to enter the residency program, and it's the same exams that certify them to practice. And I said, why nursing, they don't have this? Why they graduate without a license? And they have to wait for a long time. And therefore, I'm working with now the nursing medical schools to develop the Emirates Nursing Residency Entry Examination, in which a final year a final year nursing students could sit for the exams and be ready to practice. We also conduct the Emirati board, and the Emirati board is not an exam alone. We evaluate them during the 4 years of their residency to ensure they are competent, entrusted for unsupervised practice, in addition to the examination to get the Emirati board certificate. Most of the examinations are clinical, OSCE style, to assess their clinical competencies, and this will be applied, just so that you know, for nursing. We'll teach you how to do it. When we started with dentistry, they did not know what we're talking about. They said, what's this? And we had to teach them, we take them step by step, and now they're doing it, all the 4 specialty. And we're moving to competency-based medical education. It's not about the duration of training, it's about, well, what are the ability needed to graduate them? How we can sequence from novice to expert? How can we enhance the teacher-trainee interaction? What learning activities are really needed, and how can we best practices in the assessment? And therefore, we develop something called entrustable professional activities, EPAs, which are unit of professional practice tasks that may be entrusted to a learner to execute and supervise once he or she demonstrates the required competencies. And it's very basic. I'm not talking about the complicated things. It's an application now. If you go to App Store or Android, it's called NIHS ePortfolio. Any trainees under the NIHS, he will have that application. When he does any procedures, he will hand his smartphone to the supervisor and say, well, can you give me a feedback? And the supervisor will say, okay, well, I trust you now. This is your first month to observe only. Or you can act under direct supervision, or maybe act indirect supervision, or act with distant supervision. And then by the end of their training in residency, we have 4 to 5 years of program, you will be trusted to perform independently and can provide supervision to juniors. So the idea is, again, it's not about duration, it's about, yes, you need to entrust them. And these all units of EPAs will be collected to the program director and clinical competency committee to make a decision on their promotion. Something else, if you have interest in education, I'd like to invite you to the Emirati Medical Education Conference, which will be held February 7 to 8, 2026, Ferment Bab al-Bahar. This is our 4th version of the Emirati Medical Education Conference. And thank you.
Thank you, Dr. Mohammed Al-Hawqani, for participating with us. And please, we would like to invite you to accept our appreciation.
Thank you, Dr. Muhammad. It's our honor to have you today among us. Is any one of you have a question for Dr. Muhammad? Yes, please.
Prof. Muhammad, it was an amazing talk. Thank you so much to give us the insight about the medical education and certification. So how can institutions like hospitals, clinics participate or contribute to this process if they want to provide, like take on such programs of training? What is the process that you propose?
Very good question. So for any institution, they have to apply as institution accreditation. And we have many private, especially in dentistry. It's almost 90% now of our internship program in dentistry are in private. So the institutions, we call them institutions, it could be a clinic with a good number of patients volume, they have to apply and meet our standards. We need to ensure that there is a support from your management, there's a fund, there's a protected time, there's the environment there before we give you the institution accreditation. That's the first step. Next step is we talk about the programs, and we have, as I presented, 88 different programs that can run in any institution. Please.
Yes, please.
Thank you so much for giving us an insight into what you're doing. I just wanted to ask that, will there be any research support that the NIH gives? For
research support?
Yes.
Okay, very good. So part of most of our curriculum, there is a scholarly activity. So when you read the requirement, you'll see that any resident has to participate in a scholarly activity. We're expecting for residency program a participation in quality control or publishing an abstract or a poster. That's a minimum. For a fellowship program, we need to see a full paper. So there is a scholarly activity part. Now, do we support it? The answer, no. The institution who run the program should find a way to get a grant and support the scholarly activity. Thank you.
Thank you very much, Dr. Al-Hawqani. I'm here. Yeah, I would like to ask about the diabetic program. It's for 2 years. Is it accredited, internationally accredited, or the accreditation in your EE?
Very good question. So for any program across the world, it always starts nationally, and it will be recognized internationally, because they will go to our website, they will understand that this is a clinically oriented program, and most of the time it will go without problems. So far, we've been graduating physicians with Emirati board, and they're, mashallah, just so that you know, 50% of our physician residents are not UAE national. And some of them, they say, some of them, they go back home, and they're practicing with the Emirati board. So I don't think there will be a problem with the nursing.
Thank you very much.
Here. Thank you, Dr. Muhammad. Unfortunately, I missed most of your talk, but fantastic. Not program, because I didn't know what the program is, but the idea behind the training. There are two things. The structural training is really important because allow all the institution, when you want to appoint somebody, at least you know they tick those boxes. So you know this is being done, and the interview is just to accept or not. But usually when there is no structural training, very difficult to judge. Now my question is, because I face the same issue, so of course any higher degrees, they'll have accreditation nationally. So do you have the connection between the clinical authorities, and so those degrees being accredited by the, for example, Ministry of Health, the HA had, so when they got appointed for any job like nurse educators or any nurse subspecialty, they know where they are at the level of the licensing body?
Very good question, and this is why we're here. The beauty about the NIHS, we are a government, a federal government. linked to all the health regulators. And if you go to the PQR, you just type Emirati board. On the PQR, you'll see we are tier 1. What does that mean? So a physician, I'm talking about physician now, a physician who graduates from a tier 3 country will take 10 years to become from specialist to consultant. A tier 2, 5 years. A tier 1, which is North America, some part of Europe, and the Emirati board is tier 1. So you'll see us there. And this is why many of the clinical master programs, dentistry, now they're converting to residency program as well. They're doing dual because they're moving them from tier 3, which is master, to a tier 1. I hope that answers your question. And for the nursing, it's already aligned with the PQR. Yeah, sure.
Thank you, Dr. Muhammad. I have just one question, or I say comment. I don't see there is accredited community health nursing specialty where it will be having a positive impact in epidemiology and prevalence of disease, health promotion and disease prevention, primary and secondary, tertiary prevention. I think if we in the future plan add this specialty in nursing field, I know that United Arab Emirates already provide accredited public health in medicine college. However, I'm just want to see a nursing field having also epidemiology, biostatistical, and health promotion rule. Thank you.
Well, thank you. Just to let you know how we came up with the 5 nursing specialty. It has to be linked to the health workforce plan. It should be proposed by one of the sponsoring institution, or one of the health regulator. Because you may come up with an idea, and we spend time forming a committee and another 6 months doing the draft, and it sits on the shelf and no one take it. So the idea is, whatever we do, it should be linked to the health workforce plan, to the PQR, and also ensuring that one institution will be funding that program and it will be utilized. Thank you.
Thank you.
All the best.
Thank you so much. Thank you, Dr. Muhammad, for the inputs and the clarifications. Now, it's my pleasure to introduce Dr. Khadija Hafid, another close to my heart colleague. You know how feminized I am. So Dr. Khadija will be talking about pre-diabetes, a call to action. This is a Merck Symposium. Dr. Khadija, floor is yours.
Assalamu alaikum, dear colleagues, ladies and gentlemen, friends. It's a real great pleasure to be here on the inaugural Diabetes Educator Conference. It is such an honor, and thank you to Zainab and the organizing committee for giving me the privilege to come and speak today. I echo the sentiments of my colleagues mentioned earlier that we've been talking about having diabetes education for the longest time. Diabetes education now has a home. So congratulations, Zainab, and all the diabetes educator team. I would also take this opportunity to thank Team Merck for allowing me to participate in their symposia. Before I do that, they would like you to scan the following QR code. This is the Diabetes Educator Survey. So all of you, if you can get your phones out, just scan the code. There's, I think, a couple of questions there that you need to respond to. So I'm going to give you a minute to do that before we proceed with the talk. Okay. So my task is really to talk about why we need a call to action for prediabetes. And these are my disclosures. So the objectives are really to highlight the increasing prevalence of prediabetes. I'd like to review some of the clinical implications and screening guidelines for prediabetes, and then really highlight the role that diabetes specialists, and we've said diabetes educators, but really diabetes care specialists have in diabetes prevention. So when we look at type 2 diabetes and prediabetes, you can see it's really a continuum. And what we see is just the tip of the iceberg. Just here, type 2 diabetes is what we see on the surface. But right below this big, huge iceberg is prediabetes, characterized by impaired fasting glucose and impaired glucose tolerance. And why that is important is because for us in the region, it is a problem. In the Middle East and Africa region, we know that 1 in 9 adults has prediabetes. And so these are potential people who are going to develop type 2 diabetes. So, impaired fasting glucose, impaired glucose tolerance are this intermediate metabolic state whereby the glycemic parameters are above normal, but they're just below the threshold for the diagnosis of diabetes. And what is the percentage of people that are likely to convert from prediabetes to diabetes? It ranges from the epidemiological studies from about 5 to 10% annually. And we know that 70% are expected within a 10-year period to develop type 2 diabetes. In fact, when you have both conditions, impaired fasting glucose and impaired glucose tolerance, your likelihood of developing diabetes is even higher. So who are the individuals that are most likely at risk for progressing to diabetes? Well, usually it's older individuals, it's people who are overweight or living with obesity, those who have a very strong family history of diabetes. And I emphasize these two because we know from data that has just been published this year from our colleagues in Dubai Hospital that 70% of the UAE population is either overweight or living with obesity. And then we fall into this sort of high ethnic group that has strong family history for development of diabetes. Gestational diabetes, you've heard an elegant talk from Dr. Rahila a few minutes ago. These are also individuals that we may have to pay particular attention to. And then those who have both IFG and IIGT are more likely to develop diabetes than individuals who have just that one condition alone. So what are these, how do we make that sort of diagnosis? So, to make a diagnosis of diabetes using a fasting plasma glucose, obviously we need to have the threshold that is above 126. So in yellow, you have that intermediate state. Normal is less than 100, but if you're above 100, less than 126, then it's impaired fasting glucose. On the other hand, to make a diagnosis of impaired glucose tolerance, we use the 2-hour plasma glucose OGTT, and here we've got the threshold, anything that's above 140 but below 200. That's impaired glucose tolerance. And then if we're going to use the hemoglobin A1C targets, it's anything above 5.7 but less than 6.5%. So any abnormality, of course, needs to be retested. One test is not enough. It should be repeated and confirmed on a separate day. You can use either one of those. If you've used the fasting, you can repeat it with the HbA1c so that you make a diagnosis and have more clarity for the patient. Now, why is it important? Because both prediabetes and, of course, diabetes are associated with a number of metabolic problems. And in fact, prediabetes also predisposes to the cardiometabolic syndrome. And there's really extreme variability in the rates of progression among both adults and adolescents. We've said 5 to 10%, but much higher if you've got both the conditions. So why is it that we're particularly concerned with just prediabetes is because the risk for developing microvascular complications, retinopathy, polyneuropathy, nephropathy, are just as high in someone with prediabetes as in someone with type 2 diabetes. And in fact, we also know that the cardiovascular risk is also increased exponentially. 10 to 40% individuals may in fact have cardiovascular disease even at the state when they have prediabetes. So it's not uncommon to see in the coronary care unit somebody coming in with a myocardial infarction and the hemoglobin A1C is 5.8 or just 6. It's not uncommon to see in the stroke unit somebody coming in with a stroke and the hemoglobin A1C is only 6. So prediabetes is indeed a wake-up call, and we need to do more about more to identify these individuals, put in the necessary interventions so that they don't progress to type 2 diabetes. We know that by screening individuals, we can have better outcomes. It is cost-effective. We can help people make the change from being reactive to more preventive medicine. So in the standards of care, they do give us a guideline as to who needs to be screened. And this is adapted from the American Diabetes Association. And they recommend that we screen individuals who have first-degree relatives with diabetes, individuals who belong to a high ethnic group, those who have history of cardiovascular disease. So we screen all our patients who come into the coronary and stroke units, but also if you've got history of ischemic heart disease and risk factors for cardiovascular disease, hypertension, dyslipidemia, and so on. Individuals with PCOS, individuals who are physically inactive should also be offered screening, those who've been diagnosed with GDM, and so on. So, few questions, also from the ADA. Are you at risk for diabetes? And you will have this also in the survey at the end. How old are you? What gender? You know, it looks at things like, do you have a family history? What's your blood pressure like? Are you physically inactive? And what's your weight category? And if you score anything greater than 5, then you are at higher risk and you should be having the test. So assessment of prediabetes is, of course, advocated and recommended by many institutions, both the Diabetes UK, the ADA, and the Diabetes Canada. And in fact, we know that people who have a family history of diabetes, so if you have type 2 diabetes, the parents and even the siblings of the children have a 2 to 6-fold likelihood of developing the condition. And oftentimes, you know, and this is where we think that diabetes care specialists can come in, is when you are faced with somebody who already has diabetes and talking to them, ask about the other individuals in the family. Invite them and, you know, mention to, say you're talking to the father and say, what about your children? And what about your brothers and sisters? Have they been tested for diabetes? Can we prevent diabetes? I think we can. We can do that at an individual level, and we can do that at a population level as well. But what is it going to take? It's going to take a lot of effort in terms of delivering the right lifestyle interventions. It's going to require person-centered care goals, so we need to address the individual needs of people, and we'll also need to use some pharmacotherapy. Now, person-centered collaborative care has been highlighted, and I'm just going to read this because it's a really important statement. People with diabetes can benefit from a coordinated interprofessional team that may include, but is not limited to, diabetes care and education specialists, primary care, subspecialty clinicians, nurses, registered dietitian, nutritionists, exercise specialists, pharmacists, dentists. In other words, diabetes prevention is everybody's business, right? Okay, how are we going to do it? The clinical interventions, multifactorial, nutrition counseling, physical activity, there must be pharmacological therapy, technology, and of course, reduction in cardiovascular risk reduction. And you know, the basis of that is through behavioral approaches to try and address all those. I'm not going to go into the details of that because I only have 3 minutes left. So nutrition therapy, you're all aware of that. It's important. Physical activity has already been alluded to. But I'll mention about the pharmacotherapy and why that is important. Jaakko Tumoloto did the Finnish prevention trial 2 decades ago, and he demonstrated the power of lifestyle modification, showing that indeed with just lifestyle you can reduce the prevalence of diabetes by 58%. It was more powerful, extremely powerful intervention. And then we had the US DPP study, which then compared lifestyle with metformin, and that too showed that lifestyle intervention was extremely powerful. But we do know that there's a huge problem with adherence to lifestyle modification. Right, it's easy to do at the beginning, but to sustain it over time is what the problem is. And therefore, if you add the medication, it is probably much better or more sustainable. And this we know from the recent diabetes prevention trial that was presented, what was done actually in China. And so what they did is they took patients that had only the lifestyle intervention, and then they took patients and subjected them to both lifestyle and metformin. And so what was seen is the metformin plus lifestyle had a greater reduction in the incidence for diabetes compared to the lifestyle intervention alone. And therefore we can help these individuals, who we recognize have prediabetes, but yes, you need to have the lifestyle, but the medication also helps with the sustainability. And in fact, when they looked at who was it that benefited, it was participants who were younger than 45, those whose BMI was greater than 25, those who had hypertension. Men seemed to have benefited a lot more, and individuals who had a BMI greater than 25 with hypertension as well had a greater reduction in their risk for development of diabetes. And so that study really showed us that it was the first to show that the addition of metformin with lifestyle could be extremely beneficial at a population level. So just to give you a brief overview of the mechanism of action of metformin, this is a drug that has been in clinical use for more than half a century. It is older than I am, I can say. We know about its anti-glycemic mechanisms, but more recently we also know about its cardioprotective mechanisms. It is approved in over 55 countries, including the UAE, as a treatment for prediabetes. In fact, we have it in the treatment algorithm for prediabetes in the Emirates Diabetes and Endocrine Guidelines. This was what was published in 2020. We are going to update the guidelines that will be coming out early next year. But in the 2020 guidelines, we did advocate for use of metformin in those individuals with prediabetes as a treatment to help them to help with the prevention of transforming to diabetes. The treatment goals are really simple. We want to delay the complications. And so I have run out of time. Probably the time was taken up by the survey. But the key summary points is that we are in a situation whereby a lot of individuals are at risk for developing diabetes. We know that it's a priority for both health promotion and patient education. Education is really a key unmet need. And I am so glad that we finally have this as a conference to just address that. And then effective screening is important. Opportunistic screening, is really important. And I've already highlighted who are the individuals who need to be screened. Of course, intensive lifestyle and targeting cardiovascular risk factors is also important. And we know that metformin has stood the test of time. It can be used as an adjunct to lifestyle interventions in order to reduce the risk for developing type 2 diabetes. And with that, I'd like you to scan the QR code so that you can assess your own risk, and thank you for your attention. Looking forward to the questions.
Thank you, Dr. Khadija, for informative presentation. Does anyone from the audience has a question? We'll take only one.
Thank you, Doctor, for a great presentation. My question about that, we all know that there is a debate about using the medication for pre-diabetic patients, for pre-diabetes people that they have the risk. So either metformin or GLP-1, when we as a clinician decide that this person needs really medication therapy with the lifestyle.
So the basis of the treatment is always lifestyle modification, right? This has to be part and parcel. It is the treatment, it is part of the treatment of diabetes. You've seen that there in the algorithms that were presented, the 88 standards of care. It is the management of obesity as well. And in the management of prediabetes as well, lifestyle is the bread and butter. You can then add on the other things. The point is, where do I add on the medication? Right, so you can start at the beginning, so you reinforce lifestyle. In the 2020 algorithm that we had, we said lifestyle for 6 months and then add on the pharmacotherapy if the lifestyle interventions are not working. But we're going to revise that because I think 6 months is probably too much over time. And if the person has prediabetes plus already other cardiovascular risk factors, dyslipidemia, hypertension, and so on, why wait? Right? So depending, it'll be very individualized, but depending on what are the other compelling risk factors, it might be important to add the medication, early on in order to prevent the, transition and progression to type 2 diabetes.
Thank you. Yes. Stay, please. We'll give you the appreciation certificate. Thank you. It's always a pleasure to have you among us. We are late by 30 minutes, so we'll allow you to take 10 minutes break. You can get your coffee and food inside the hall and enjoy eating while listening to the upcoming presentation. So you will be hearing the bell soon, so please grab some coffee and food and come back. Thank you.
Thank you everyone for coming back after coffee break. And we are going to move on to the next session. So it gives me a great pleasure to introduce, I'm chairing this session with Ann Matter. Okay, so we have got 3 talks in this session. So we are going to kick off with the first important one. And I think this is what I find is lacking in this region is the role of podiatrist in a multidisciplinary team. I have had the pleasure of working with Sarah for the last 8 years, so it gives me a great pleasure to introduce Sarah Khan, who is working with me as a podiatrist in the multidisciplinary team at Genesis Healthcare Center. She's also I haven't found any person who is so passionate about doing feet. So she is also does Special Olympics in UAE and recently was awarded an award for doing that as a volunteer work. So without further ado, I'll ask Sarah. The floor is yours.
Hi everyone, and thank you so much for having me here today and listening about my chosen subject for life, which is feet. Not everybody's favourite topic, but do bear with me, and I hope it's not too boring for you. So as Khadija just said, multidisciplinary, it's everybody's business. I really like that she said that because it is. It's not sticking your nose in, it is everybody's business, and the diabetic foot is complex. I thought I'd start with a little bit about what podiatry is. I'm sure many of you have worked with podiatrists or come across podiatrists, but it is one of the things I've found in the region that sometimes people are a bit unsure about what we actually do. Because there isn't a training program here and not everywhere across the world either. So we are specialists in the foot, ankle and lower limb. We assess, diagnose, treat and prevent conditions affecting the foot, ankle and lower limb. So this could go anything from biomechanics, sports injuries, looking at the general podiatry, which would be your nails, your skin conditions, and of course then diabetes, which is why we are here today. So, the foot in risk for diabetes. I think the foot, say, is one of the areas of the body that is really forgotten about. How many of us just get up in the morning, pop our shoes on, and off we go. So it's not just the foot in diabetes. I think in general, we really do take our feet for granted. But with diabetes, some of the main things that can happen are peripheral neuropathy. So this is damage to the peripheral nerves, meaning that patients can lose their sensation in the feet. So if they are walking along the beach and they step on something, are they going to feel it? I had a very interesting case very early on in my career where a patient had come in with a wound on the top of his toe. Couldn't understand where it had come from. And when we put our hand inside his shoe, there was actually a milk bottle cap inside his shoe that he'd been walking around for who knows how long, but had no idea because he couldn't feel it. Peripheral arterial disease, again, the reduction of the blood flow to the foot. So this can impair the wound healing. Patients aren't able to heal as well as we would like to. And of course, then that increases their risk of having gangrene and obviously leading to an amputation that we really want to avoid. Other things with diabetes are things like they have a reduction in the ability to fight infections. And say because they're sometimes unaware of what's going on with their feet, it can lead to things like ingrown toenails, fungal infections, calluses, and deformities on their feet as well. So how we kind of try and tackle this, or hope to tackle this, is with a diabetic foot assessment. Now, every diabetic patient should be having this done at least once a year. Doesn't always happen, and I've had patients that have been diabetic for 30 years and said, I've never had this done. What are you going to do to me? What are you going to prod and poke me with today? Nothing too nasty and serious, but what we do is we're looking at their medical history, the history of their foot, any history of any conditions with their feet, looking at the skin and nail condition. Is there anything that stands out that could potentially cause a problem? And then we go on to the testing of the foot. So looking at their sensation, which is done with a 10-gram monofilament. Patients panic with this, it looks like a needle, and they go, don't do that. No, it's fine. It's just a pressure test on 5 points of each foot, seeing if they can feel something and do they have that protective sensation that they're going to be aware of a problem. And then the vascular assessment, so looking at their blood flow. How is their blood flow to the feet? So we can use a Doppler for this if we have access to ABPI or TBPI. We can use that, but Doppler is a good starting point, and then we can always refer on to the vascular team if we need to. At home for patients with regards to the blood flow, they can also look at things like, are their nails still growing? Is there any reduction in the hair growth on their feet as well? These can be little telltale signs that something is going on as well with their blood flow. Footwear evaluation, like I just mentioned with the patient, with the wound on the top of the toe, not just looking at the shoe, although how many times I have to say per day, we have to wear the right shoe for the right task in hand. Here the footwear can be a little bit of a challenge because of the sandals and the slippers that patients like to wear. But check inside as well. Make sure there's no wrinkles in the lining of the shoe and anything that could cause a problem for them further on. And then what do? We classify their risk. So a nice traffic light system here, where we've got the low risk with your green. So these are the patients that you want to be seeing annually, once a year, and hopefully as diabetes educators, you can encourage them to come along and see the podiatrist or even the nurse, the diabetes doctors as well, to do a little assessment on the feet. Our moderate risk patient, where you might have a little bit of loss of sensation, a limit in the blood flow, we want to see them every 3 to 6 months. And then your high, very high, and active patients, these are the ones that we need to be getting in a lot quicker, especially our active ulceration patients. Again, these patients may have had a wound on their foot, have no idea what's going on, how long it's been there. Let's get them in so that we can prevent any further complications with that. So why do we need multidisciplinary? Why do we all need to work together? Of course, it's for the patients. There's a very, very high prevalence of people with diabetes developing an ulceration, about a third of those patients. And that obviously leads to an amputation risk, which we want to avoid. We want to salvage these limbs as best as we possibly can. There's an economic burden here. We're obviously fortunate to have insurance, but there is that cost element that comes with having a long-term ulceration, and that can be also to the patient if perhaps they're unable to work because they have a wound on their foot. That can be problematic to their families, to their ongoing health and mental health as well. And of course, big one, we want the prevention. This is where we can all work together really well to make sure that these problems aren't happening, and we also empower the patients to do what they need to do as well. This is quite an interesting infograph here, where we've got the relative 5-year mortality with patients that have diabetic foot or diabetic foot ulcerations or amputations. And as you can see, the title says, are diabetes-related wounds and amputations worse than cancer? It's quite a strong statement to make, but yes, in the grand scheme of things, yes, they are. You can see the green bars and how that actually has a massive impact on the patients and their life. I often used to say when I worked in the UK, if you had 3 buckets, you had diabetes, heart disease, and cancer, and you had a £1 coin, which one would you put that one in? Probably the cancer, but really it should be the other way around. We need to be really putting that emphasis on diabetes and the risks that come with it, because some people really play it down, and the education side of it, as you guys know and have jobs, is really, really, really important. So the MDT, what does it look like? I really love this image because it's a circle. A circle is fluid. It's got no edges. So again, everything is going round. These patients, our diabetic patients, our diabetic foot patients, they're not just jumping and then they're out. They're going to be going between all of us, everybody, probably through their whole life, because it's not something that's going to stop, because we'll have the treatment of what's going on at the time and then prevention of it coming back, or how do we make sure things don't come back. So I really like this because, say, the patients can move between these layers. And here you've got the diabetic foot patient in the middle, the vascular surgeon, orthopedic surgeon. I hope there's no orthopedic surgeons here. We want to avoid them going to see those. We don't want anything chopped off, but also a very, very important part of the team. Podiatrists like myself, and then the endocrinologist, diabetologist. These are your kind of core team that are going to be treating your patient. And then you've got your outer circles, who we hope that they can refer into us, and we refer out as well. So I really like this image, and say the circular fluid image as well, to say that patients are constantly moving. So what do the guidelines say? My 2 favorite guidelines, NG19 by the NICE guideline, and IWGDF, Guideline on Prevention and Management of Diabetic-Related Foot Disease. they're quite similar in a lot of ways, and the main takeout points are you're looking at early identification of any potential risks, appropriate referrals into the MDT, into the team. The teams you can have would be your preventative team, but also the management team. And there will be a level of crossover between these two teams as well. Protocols and pathways, of course, very important. You know, we're always looking for what does the international guidelines say? What is our best practice? So working together and having those with the guidelines is really, really important. And obviously then monitoring. You know, how are these pathways working? How are we working as our MDTs as well? Sorry, I meant to give a little bit of a disclaimer on this one if anybody was squeamish. So sorry, but some of my lovely pictures that I've had of patients over the years. Sorry. I said nobody would ever want to hack into my computer. They would have a shock, that's for sure. My phone is feet, dogs, and children. My children. So nobody would ever want to look. But you can see the different locations, perhaps different reasons. Wounds are quite, let's call them quite fickle. They like stability, like we all do. They want good diabetes control. They want good infection control or no infection. And they want pressure relief as well. So these are some of the wounds that I've seen. I've seen many, 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 many more. But what happens if you have a patient that you are speaking to and they say, oh, I think there's something wrong with my foot. And they take off their sock and they present with something like this. My answer would be, please send to podiatry. Please send them in our way so we can have a look and we can triage the patient how we need to. So looking at their history, doing those diabetic assessments, and what are we going to do? Is there any infection? How do we move on to prevent that wound getting worse as well? Infection management, I just wanted to touch on this quickly, because you may have a patient that comes in that is feeling a little bit unwell. You know, they feel a bit fluey, they haven't been sleeping, their diabetes is a little bit, say, out of control. Is there an infection going on? That could be something that the patient is perhaps unaware of, but picking up these little trigger signs that perhaps means, okay, we need to get you in, we need some antibiotics. We can classify, again, the severity of an infection, mild, moderate, and severe. Severe, ideally, we probably need to get them into the hospital, perhaps for some IV antibiotics as well. But ideally, we start with an oral antibiotic and take a swab of the wound as well, so that we can see what's going on, what bug is growing. Do we need something more specific that's going to actually target what's going on? Again, to kind of stabilize that wound so that we can get the best treatment out of it. So these are the two guidelines. We've got the NICE and IWGDF. These are really, really nice flowcharts that look at how we deal with a patient that has infection and, say, trying to prevent that amputation. So two really, really nice little flowcharts. I talked a little bit earlier about the peripheral arterial disease. Up to 50% of diabetic foot ulcers involve PAD, which is quite a high figure, actually. And this can lead to non-healing amputation and, unfortunately, like we saw in that chart, death. So early recognition of any peripheral arterial disease, plus a prompt referral through to the vascular team, and managing it with an MDT is going to mean that we've got better healing and a better chance of preserving that limb. So sending into your vascular team, to the vascular doctor, do they need to do a duplex scan? And do they need revascularization? Or is it something we just need to monitor? Very important. Wound classification. This is actually something that I think really helps tie the MDTs together. Because if you have a patient's notes, you're going to know, okay, on this day, this is the classification of this wound. 2 weeks ago, this is the classification. Is it getting better? Is it getting worse? How is this wound reacting to our treatment? Do we need to look at our treatment plan? Do we need to change our treatment plan? what are we missing? So the purpose of wound classification is to standardize our assessments, manage the patient, and make sure that, again, that those outcomes of the wounds are the best that they can be. So the two main ones, and the two that are listed in our international guidelines, are SINBAD, which is site ischemia, neuropathy, bacterial infection, area of the ulcer, and the depth. And these are a 0 or 1 score. So this is quite a nice, I'd say simple way to score the wounds. And the possible score is 0 to 6. 6 being the worst. We don't want the 6. We want the 0, but something in the middle. But it helps us, say, to classify and see what is going on. Wi-Fi is a little bit more in depth, and this was developed by vascular surgeons, actually. And this is wound ischemia and foot infection. But it's classifying how threatened that limb is when it comes to how perhaps close we are to amputation and how quickly we perhaps need to act on that. So say two quite nice things that, or two classifications that are quite easy to use, and any of us can use it. It can be the nurse, it can be the doctors, it could be you guys. If you see a wound, have a look at SINBAD. Super easy to kind of follow through and go from there. Offloading, again, this is probably my gold standard. Podiatry, I would say it's maybe one of our bugbears, that it's perhaps not done enough with the offloading of the foot. But there's different types of offloading. But the main thing is to get the pressure off the wound, make that wound more stable, make it a happy wound, and reducing that pressure. So different types. We've got non-removable devices, which would be your Plasticast, basically. Some patients are not going to be too happy with that, unfortunately, but we have other options. We have removable devices. My favorite, I love semi-compressed felt, as me and Anne were just discussing about. It's sometimes the easiest, and it can be in some ways the most effective for the patient's case. And obviously wheelchair or bed rest, again, not always a possible option because of work, and perhaps the patient doesn't want to do that. Understanding what the patient needs is quite important in this, because you don't want to put them in a total contact cast and they go home and they take a chainsaw to it and try and get it off. When I was 3 years old, I pulled my Plasticast off my arm because I didn't want it on there. So I'm a bad patient in some ways, but understanding what the patient's needs are there as well. Charcot foot, I just again wanted to touch on this because this is sometimes, again, something patients aren't aware of what's going on. This is a red, hot, swollen foot, but they have no pain, and there's not always a reason for this. Sometimes they may have had a very simple little trip, but it's basically a destruction of the structures of the foot, which can sometimes then leave them with a rocker bottom foot, like a rocking horse, which obviously is an increased pressure point, and obviously can limit their mobility in a lot of ways. So if the patients come in and they make, a few remarks about their feet being like that, just ask them, check what's potentially going on, and if this is the case, please do refer them in. So what can you guys do for us? How can you help us with the diabetic foot and diabetic foot ulceration? I think the most important thing, and thank you so much for doing this, is empowering that patient, giving them the ability to help themselves. I think this is so important in everything that we do. Having the awareness of what can happen, how can it go wrong, why can it go wrong, to reduce their risk. And the prevention then, what can we all do here? Patient education, the offloading, patient self-care, making sure that they are coming in for those annual checkups, or quicker if they need it, having that risk assessment done and recording it so that we can see what is the difference year on year, hopefully nothing. Hopefully they're going to be good patients for us. I just wanted to finish with a little case study. So this was a very dear patient of mine and Dr. Rahila's. Unfortunately, he has since passed away, but probably one of my favourite patients, which I probably shouldn't say, but he was a 66-year-old Welsh man. I'm also Welsh. He's a businessman, he was married with 2 children, and he got admitted to the hospital with shortness of breath. Now I can still hear Dr. Rahila's heels coming down the corridor when she was marching him down to see me. He did not like coming to the hospital. He did not like doctors. He had very poorly controlled diabetes, had hypertension, chronic kidney disease, and he'd had previous amputations. So for him, he thought every time he was going to see a doctor, there was going to be a problem. So in he comes to me, not very happy to be seeing a podiatrist. But I said I was Welsh, and he changed his tune. And what we actually managed to achieve with this patient, although it maybe looks like we still have wounds here, but we gave him his quality of life. What he really wanted to do, he wanted to be able to wear a normal shoe. He was a businessman who had to go to meetings. He wanted to wear a shoe. And he also wanted to play with his grandchildren. He didn't want his grandchildren to think of him as being unwell. So what we did, twice a week, semi-compressed felt, so he could wear a shoe. He did not want to have a plaster cast on, although it would have been the best thing, textbook, but he wouldn't have come back. And because he came back and he built that trust with myself and Dr. Rahila, we also got him into the cardiologist. If he had to go for an x-ray, he would go. He didn't dare mess with me and Dr. Rahila at all. One time we needed IV antibiotics for him. He didn't want to be admitted, but what did he do? He came in every single day. And we managed him because he really trusted us, and because we didn't just say to him, do this. So it's having that nice rapport with the patients, understanding their needs. And when he unfortunately passed away, his daughter came to me and Dr. Rahila and said, thank you so much. Because of you two, my dad kept going for a lot longer. And I think that was a really lovely thing and a really positive thing to take away from that situation. To say, working together with the patient, it's not just how we work together as colleagues, it's everything. It's looking at that circle, bringing it back, having that fluid flow between all of you as well. So thank you so much for having me. Hope I haven't been too boring. Thank you.
Anyone? 5 toes in each bit. Okay, I have one question, Sarah. So when the patient comes and sees us in the clinic, any diabetic patient, and I think we physicians are still not very good at assessing the patients, and the common thing that you will hear is, yes, you're going to preg, and I don't want that done, yes? So what is the best way forward, how we can avoid what you just show us?
Okay, so again, it's the approach to the patient, I think. It's educating them, not telling them. I think it's, say, putting that power in their hands for their understanding. Another common thing I've heard over the years here, when you're newly diabetic patients and they say, my auntie had an amputation or my dad had an amputation, they have a fear. And I think it's quite important to not put the fear into them. They need to be aware that this is serious and there are complications that can happen, but empowering them to go and see the podiatrist once a year, know that that needs to be done and it is important.
Thank you so much.
Thank you very much, Tara, for that excellent presentation. You made us podiatrists proud today. Before I introduce the next speaker, I'm just going to share a short story from my practice, just to tell you, to let you know that how clear and practical education really important. Abdullah, he comes to the clinic presented with an ulcer on the front aspect of his right hallux. So after examining his footwear, I noticed that there is an indentation corresponding to the area of the ulceration. So what I did, I said, Abdullah, this is a culprit, you have to change your footwear. After a few months of persuasion, one day he came proudly walking to the clinic, and he introduced his new shoes. Excuse me. So I said, Abdullah, that's really good. And before I actually get a chance to celebrate, he told me that he wear his old shoes at home. So this is actually tell us, technically he followed my advice, but I still had to make it clear, the way that I provide my advice to the patients. So I'm going to introduce our next speaker, Dr. Ahmed Al-Aboudi. He's a consultant diabetic endocrinology at Imperial College London, and he's also a honorary clinical lecturer on diabetes endocrinology, and he's a clinical associate professor in Internal Medicine, College of Medicine and Health Science. Welcome, Dr. Abdullah.
Can you hear me? Is it on? Okay, fantastic. Well, first, thank you very much for the kind invitation. It's a real pleasure to be here this weekend, seeing many friends and colleagues. And congratulations on the conference. I think it's a really important addition to the academic calendar in the UAE. I was given this task talking about diabetes technology in the UAE, and it's quite interesting to talk about diabetes technology to the most tech-savvy members of the diabetes healthcare team. So first I'm starting with two of my patients, because it's all about the patients. So this is the first patient, an 18-year-old, first visit to the adult clinic. And even before I see the patient, I received a phone call from the lab. You have a patient with a HbA1c of 14%, random glucose of 20 millimole per liter, and 4+ urinary ketones. So he was diagnosed with type 1 diabetes at the age of 1, and he was prescribed the 780G for the last 2 years. The reason I'm saying prescribed, because as you can see clearly from the download, he's not using it. Before the patient comes to my room, his mom spoke to me. She told me she's quite concerned about his attitude to diabetes. He's never been compliant. So, and as you can see, after 2 weeks, time in range of 51%. So we'll talk about that at a later stage. On the other extreme, another patient, 67-year-old lady, had type 1 diabetes for 35 years, using the 780G for the last 2 years. And as you can see from the download, her time in range is 85%, but she's not happy, right? And 6 weeks later, time in range 95%, almost normal glycemia. So with that, this is the outline of the talk, an introduction. We'll talk about what's new and what's next. So, diabetes technology. I'm sure you would agree with me that for diabetes technology, it was synonymous with type 1 diabetes. But now we're seeing more and more it's expanding across the spectrum of type 2 diabetes. And similarly, with type 2 diabetes, we had these amazing therapeutics, incretins, SGLT2 inhibitors, that now progressing to be used in patients with type 1 diabetes. And you can see here what diabetes technology entails. So on the top left corner, we have the CGM. On the other corner, we have the insulin pumps. And when we combine them both together with an algorithm, and we have the automated insulin delivery system, magic can happen, right? However, it still requires patient's input. So the patients need to be able to count carbohydrates, announce carbohydrates 15 minutes before a meal for us to achieve the target glucose. Diabetes technology also entails cloud-based platforms that allows for remote monitoring, and also digital tools and AI. I'm sure you're all aware of the ADA standards of care, and I'm highlighting with these two boxes that in 2025, ADA has removed the distinction between MDI and basal-treated, insulin-treated type 2 diabetes. Okay? So they recommend CGM for any insulin-treated diabetes. Also, they added the sentence to consider CGM in adults with type 2 diabetes treated with glucose-lowering medications other than insulin. Of course, they do recommend automated insulin delivery system. It should be the preferred method of insulin delivery in youth and adults with type 1 diabetes and other types of insulin-deficient diabetes, and they stressed on the importance of ongoing education in person or remotely. Now, this graph, and you can look at this graph from two angles. Let's start with the positive angle first. You might notice here that there is this light blue line. I don't know if you see it. This is the age of the patients, and this is the HbA1c. So this light blue line is the achieved HbA1c with the use of the 780G. Real-world evidence included 100,000 persons with type 1 diabetes. So fantastic. So the other two lines are data from the type 1 diabetes exchange. And as you can see here, in most of the patients with type 1 diabetes, target is not achieved. So I'll take the analogy of the iceberg from Dr. Khadija's talk. So these are 100,000 subjects with type 1 diabetes. So using the automated insulin delivery system efficiently, they are motivated, they have access to care. But how many patients with type 1 diabetes globally? More than 9 million. So this is the tip of the iceberg. Okay? We also have significant number of patients who have automated insulin delivery system, but not using it properly. I've shown you an example. We have patients who have access to automated insulin delivery system, but refusing to have it. And we have the largest proportion of patients with type 1 diabetes who do not have access even to good care. Right? So we need to be aware of that. And this is really important, and I'll tell you why. When I look at advances in technology, what I'm looking for? I'm looking for improvement in technology that would tackle all these problems. So patients already motivated to use the technology, can we make their life better? Those who are not using the technology properly, how can we motivate them to do that? How can we improve utilization? How can we improve uptake? How can we make the life of clinician easier? In the UAE, we have the standards of care. This is such a solid document that was published last year. And I can see that there is room for improvement. It still makes a distinction between basal insulin and MDI-treated type 2 diabetes. So CGM is only recommended for MDI-treated type 2 diabetes. And they didn't mention anything about non-insulin-treated diabetes. The other thing, the other document on the right-hand side, this is from Daman, the largest payer in the UAE. And as you know, there is a gap with regards to coverage. So not everyone have access to good coverage. You can come across a patient who have access to automated insulin delivery system, and the following patient, the insurance is not even covering a CGM. So there are many gaps that we can tackle. And another gap here is these red circled devices are the devices available in the UAE. And I'll give you an example. Omnipod 5 that we're expecting to get. When was it approved by the FDA? Almost 3 years ago, right? So there is a gap, or there is a lag. So with that, I'll be talking about what's new for diabetes technology in the UAE. So we'll be talking about new sensors and how we assess them. We'll be talking about expanding CGM use to new indications. Pre-diabetes, for example. Can we use CGM for pre-diabetes? We'll be talking about new CGM metrics. I don't know if you've come across TING, or time in normoglycemia, or time in tight range, AI tools, and adjunctive therapy in type 1 diabetes, because these things, we are using it now. So these are the three sensors that we're using now in Imperial. This year, we have the Libre 2 Plus and the Dexcom G7. On the right-hand side, this is the Guardian 4. It's more than a year old now, and it's used exclusively for patients using the 780G system. And when I think about assessing a sensor, I think mainly about three things. Is it accurate? Can it communicate with an automated insulin delivery system? And does it have predictive features, how the algorithm is like? And this is quite important because we are getting proliferation of the CGM systems coming to the UAE. Okay? So we need to know what we are prescribing for our patients. With regards to accuracy, I'm sure that you've come across the mean absolute relative difference. And this is a measure that looks at the relationship between sensor glucose and the reference glucose. The closer, the smaller the number, the more accurate the sensor is. And as you can see, this is a historical graph that when we started to have CGM almost 30 years ago, it was 25, and now it's below 10%. So these two sensors, they have an MRD of around 8%. However, MARD does not give the full picture. Okay. The MRD, it gives an overall estimation. But you need to look mainly at the accuracy in the hypoglycemic range, because this is the range where most of the sensors can have reduced accuracy. An example, this is what's called consensus error grid, looking at the relationship between sensor glucose and reference glucose. And I'm sure you would agree with me that the graph on the right would show closer relationship compared to the one on the left, where there are many outliers. But MARD, 8% on the left, 12% on the right. Okay? And because of that, the FDA now uses the integrated CGM criteria to assess sensor accuracy. And this looks at the relationship between the sensor glucose and reference glucose at different glycemic ranges. So the two sensors fulfill the iCGM criteria, and both of them connect with the coming Omnipod 5. With regards to the algorithm, while Libre have threshold alarm, Dexcom have predictive alarm, so it would give you 20 minutes earlier when it's expecting glucose level to fall below 55 milligram per deciliter. Was called urgent low SU alarm. The second point I wanted to talk about is expanding CGM use across type 2 diabetes spectrum. As I've mentioned, while the ADA has removed the distinction between MDI and basal insulin treated, we still have this distinction here. So how do we deal with that? My patients who are, or our patients who are non-insulin treated, but really need to progress to insulin therapy, where we face huge resistance for patients to start insulin, I tell them, listen, I'm going to give you three things. You will have bolus insulin, you will have CGM, and you will have education. And I will see you in 4 weeks' time. I don't want to see any reading above 180. You can either use low carbohydrate diet or bolus insulin or mixture of both. And it's usually work. And it's a good way to introduce patients to insulin. What about patients who are non-insulin treated but early at the spectrum? There is extensive evidence to show value. This is a meta-analysis showing increased time on range by 8.5%, but there is loads of real-world evidence as well supporting use of CGM in non-insulin treated type 2 diabetes. So how do we deal with that when it's not covered by insurance? I think it's really important to counsel patients about the value of CGM. And then they can use the CGM, they can self-fund, using it periodically rather than continuously, and certainly they will continue using it if they find a value. Pre-diabetes, what about CGM in pre-diabetes? I don't know if you're getting patients, I'm sure that you get patients with pre-diabetes asking about the value of CGM. And the profile of these patients, usually middle-aged, highly educated, well-read, and they would come to ask about CGM and pre-diabetes. We don't have evidence, but we know that pre-diabetes, as Dr. Khadija has mentioned, is not a benign condition. It's not only because the patients are at increased risk of progressing to type 2 diabetes, but we know from this meta-analysis that it is associated with increased all-cause mortality, cardiovascular events, cardiovascular mortality, stroke, AF, chronic kidney disease, any cancer, and all-cause dementia. So it's not a benign condition, and I'm sure that you're aware that some would call for changing the threshold for diagnosing diabetes. Why do we stick to the 6.5% when we have a condition that's associated with all that? CGM for pre-diabetes, what are the best metrics? First, we need to know what's normal. And here comes, I think, the value of this new metric, TING, or time and tide range, between 70 and 140. In patients who are normal, 95% of CGM data usually within this range. And when the patient starts to progress to pre-diabetes, most of the spikes tends to happen in this yellow zone. So if you look at time and range defined by 70 up to 180, you will miss it. Okay? And this is beautifully explained in this paper. So I'll just explain this graph. This is the A1C, and these are the glycemic spectrum. So here is normoglycemia, here is pre-diabetes, and here is type 2 diabetes. And this blue line is time in range, and this red line is time in tight range. If you rely on the time in range, it's almost flat, so you will miss pre-diabetes. But if you use time in tight range, okay, you will be able to diagnose pre-diabetes. Having said that, CGM is not a diagnostic tool. It's a monitoring tool, and it's very useful, a powerful behavioral modification tool. But you can tell the patients, we know that if your time in tight range starts to fall below 86%, you likely have progressed to pre-diabetes. If it's fall below 60%, you likely have progressed to type 2 diabetes. So, taking us to this new metric, is it a treatment target? It already is a treatment target in pregnant ladies, okay? But what about general population? To be able to answer this question, I think the first question is this associated with any benefit? Is there any evidence that using TING as a treatment target reduces complications? It's early days, but there is this observational study that looked at 800 subjects with type 1 diabetes, and each 10% increase in time in tight range was associated with 23% reduction in microvascular complications and 35% reduction in CVA. Early days. Will I use it? I think not yet. Can it be achieved? It can be achieved in highly motivated patients using automated insulin delivery system. But we need to be mindful that it can be associated with increased pressure and burden on the patient. AI tools. So, and the question with regards to the AI tool, can it help us or replace us as healthcare team? And can it help patients? So there is this paper, I would describe it as an old paper. It was published early this year, okay, using the ChatGPT Model 4. And since then, there are 5 models for ChatGPT has been released. So what they did, they had 10 cases, raw data that got 10 ambulatory glucose profile from them, handed over to a physician, and the raw data was presented to the ChatGPT for analysis. And in summary, ChatGPT did really well with regards to data analysis, but with regards to translating finding into clinical significance, it was lacking. So not yet replaceable. What about helping patients? Carbohydrate counting. We know carbohydrate counting, it's really troublesome. And we know many patients are struggling to do it properly, and many of them forget to announce meals before they have their meals. And that certainly impacts control. So there are these meal analysis from food images using AI. Many of our patients now use the ChatGPT. There is an app called Snack, and there is a ChatCGM, which is in Telegram. Any evidence? There is this paper that was published 6 weeks ago comparing 3 LLM models, presenting images to estimate weight, energy content, macronutrient composition. And I'll take you to the conclusion it was not yet suitable. Helpful tool, and I'm sure that patients who would use this, they're already motivated. Okay, so these are patients who would already be doing carbohydrate counting and announcing meals. What about more specific apps like Snack or ChatCGM? So I've tried ChatCGM. So that was a delicious 1 kilogram lotus cake that miraculously 3/4 of it disappeared 5 minutes into the fridge. So I took a photo, and it gave me a total carb estimation of 50 grams. So this is a chatbot, so it's quite intuitive, okay? But the reason I'm presenting this is artificial intelligence should not replace human intelligence. So when I said that the weight that you estimated is wrong, this is 250 grams, the carb estimation completely changed. So I tell my patients about that, but I tell them, yeah, use common sense as well when you're interacting with these apps. Snack, there is a paper that was published 2 weeks ago. It's a small randomized controlled study of 44 subjects with type 1 diabetes using automated insulin delivery. Baseline time in range was 74%, quite high. Okay? And they were randomized to either using Snack or standard carbohydrate counting, and they used it for 3 weeks. Primary endpoint was time in range. And you can see here that actually those intervention group had better time in range compared to the standard group. And after they stopped the app, all the benefits disappeared. But remember that, okay, we need to go down to reality. Okay? So when we talk about AI, this is for the tip of the iceberg. Okay? The most important are the people with diabetes. And us, as part of the stakeholders looking after patients of diabetes, we need to do the best to ensure that the general patients are well motivated to use the technology properly. So if I take you back to the first patient, what did we do to achieve a bit of compliance, time in range of 51% within 2 weeks? Basically, revisited education. I mean, we're fortunate, we're supported by a fantastic team of educators at Imperial and Dietitian, but we kept it simple. And the main thing is trying to empower the patient. I told him that now you're coming to the adult service. I want your mom to take the back seat, and you're responsible for your health. And I was really ecstatic when I saw his name on the list after 2 weeks. Most of those patients do not come in their scheduled appointment, but it did with him. So I think this is the most important slide in this talk, that the most important component in all these systems is the person with diabetes. Simply having a device or application does not change outcomes unless the human being engages with it to create positive health benefits. This underscores the need for ongoing education and training. The second patient, what did she do? Mounjaro. Why am I talking about Mounjaro in a diabetes technology talk? It improves glycemic outcome, weight loss. We know that 2/3 of our patients with type 1 diabetes are either overweight or obese. Cardiorenal protection and achieving a fully closed loop in those using automated insulin delivery system. So this is why I brought adjunctive therapy here. And now, I don't know if you've heard about it, we have Thiqa obesity program in Abu Dhabi for Thiqa 1 and Thiqa 2 holders. So that's a potential for our patients who have type 1 diabetes to be on this drug as an adjunctive therapy together with automated insulin delivery system. Then, what's next? We'll be talking about AI-enabled CGM, multi-analyte sensing, non-invasive CGM. We get asked a lot about that. Automated insulin delivery system, and the fully closed loop. So, with regards to AI-enabled CGM, again, we're expecting the next quarter to have the AccuCheck Smart Guide, which has AI feature, and Stelo, not yet in the UAE, but this is a Dexcom app which can be bought over the counter. It's not licensed for insulin-treated diabetic. It can be bought over the counter, nonetheless, in the US and the UK. Stelo has a generative AI model using Gemini. AccuCheck Smart Guide, it has a machine learning that takes into consideration the current glucose level, rate of change, unconsumed carbs, insulin on board, previous CGM levels, and time of the day. So there is the normal CGM app, but there is also what's called Predict app, and it gives you 3 predictions. Low glucose expected within the next 30 minutes, the glucose pattern over the next 2 hours, and overnight glucose level over the next 7 hours if there is predicted hypoglycemia. There is no clinical studies as yet, only in silico study. We saw some real-world evidence in ASD about 4 weeks ago, but certainly we need to have some clinical studies to show the value of such a system. Multi-analyte sensing, Abbott is working on a continuous glucose and ketone monitoring, and Sabionic has a continuous ketone monitoring. What would be the value of measuring ketones? First, it will provide an early warning symptom. So hopefully it would reduce the risk of DKA. And the second thing, I think it will provide a safety net for the use of SGLT2 inhibitors in patients with type 1 diabetes. As you know, SGLT2 inhibitors is associated with increased risk of aglycemic DKA. Connectivity, insulin pens, we don't have it as yet. This is really important with regards to proliferation of sensors with improved accuracy. So, as I said, we have many sensors, and I think having more sensors with improved accuracy will increase competitions between the manufacturers, and that will result in downward pressure on cost. And this will completely change the equation of the cost effectiveness. So that will hopefully convince the regulator and the industry and the payer to expand the use of CGM into different education, into different categories. Pre-diabetes, obesity. That's an example. The Say Bionic, the next generation, which is GS3, and I've highlighted here the mean absolute difference. This is the measure that we need to look at when we're looking at accuracy in the hypoglycemic range. And I've also highlighted the mean absolute relative difference. So it seems to be more accurate. So this is welcome to have more sensors that are more accurate. Evidence supporting expanding use of CGM. I've mentioned non-invasive CGM. So the other week I got a patient who told me I stopped Libre and now I have this watch from Timo that can measure glucose non-invasively. Of course, it was simply a random number generator. I'm sure that you followed that in the news about BioLink Shine that was marketed as non-invasive. It's not true. It uses microneedle technology. So as you can see in this image, so around 250 microneedle arrays that taps into the dermal interstitial fluid. It received a de novo classification from the FDA, not because of the technology, but because it's looking at glucose range rather than glucose level. What's next for AID? We're expecting Omnipod 5. It's slim, it's tubeless, it integrates with 2 good sensors. In the US, it can be used with a mobile app, not here yet, in the UAE. And it's licensed from the age of 2 years of age. While the 780G, the only automated insulin delivery system in the UAE, is licensed from the age of 7. Pipeline for Medtronic. Simplera is in Europe and in the US. Instinct, which is the new sensor from Abbott, 15 days. There is the Medtronic Extended Infusion set for 7 days rather than 3 days. They're also coming with a patch pump in the next 2 years. And the algorithm, they're working on a smart card advanced algorithm, which is a fully closed loop, does not require meal announcement. There is evidence in pediatric now from the 780G, the Lineage study, type 2 diabetes, 3 automated insulin delivery system approved by the FDA in type 2 diabetes. Pregnancy, CAM-APS is the only one approved by the FDA. It goes a target level all the way down to 80. We heard yesterday, Medtronic goes down to 100 milligram per deciliter, Omnipod 110 milligram per deciliter. Fully closed loop, which will make huge difference to our patient, can be either by advances in algorithm or therapies. AI, we haven't talked about decision support system, we haven't talked about early risk detection, we haven't talked about using AI for retinopathy detection. In summary, significant advances in diabetes technology and AI, barriers and gaps in healthcare system we discussed. Ongoing education support is essential, but however, there is a need for an agile framework for timely appraisal and adoption of these technologies. Thank you. And sorry for overrunning and for not hassling me about it.
Okay. If any questions, please do ask in the lunch break. That's what I would say. Yes.
Thank you.
The last session for this one is Dr. Khadija. So I'm just going to invite her. We have already introduced her. Thank you, Khadija. She's going to talk about patient-physician communication in diabetes care.
Assalamu alaikum once again, and thank you for inviting me to give this talk. The last 2 talks had 2 things that they underlined. Communication. Communication with the patient in order to improve the quality of life. Even with technology, we needed communication in order to get that time in range better. So, therapeutic patient education is what we need, whether it's the physician, the diabetes specialist nurse, whether it's the podiatrist, every one of us needs to have a therapeutic way of talking to our patients. Because remember, healing begins with the way we speak. Now, with regards to communication, I'm going to give you also a story about one of our patients who needed to start insulin. And, he was with the diabetes educator, and, normally we have like an orange ball, to demonstrate how to take the insulin. So that particular day, the orange ball went missing, but the patient had his own orange in his bag, so we used that. And off he went, and comes back. A week, I think he was told to come back, and they look at his readings, and of course the sugar readings were all over the place. And then they asked, did you take your insulin? And he said, yes. Can you show me how you took your insulin? And the chap pulls out his orange. That's where he was injecting his insulin. So communication is about feedback as well, and I'm going to highlight that. So before I do that, you've seen my disclosures, they haven't changed. So what I would like to outline is this awareness about psychosocial barriers that can contribute to therapeutic inertia and how we communicate with patients, how we can improve our skills in assessing health literacy, because that's an important barrier for self-management, and how we can introduce motivational interviewing techniques in order to improve patient engagement. And you've heard from the talk on technology that patient engagement is really essential. So our role as healthcare providers, I think, is really to improve that effective communication, build a therapeutic alliance with the patients. And I love the example that Sarah gave with the patient. It was really a therapeutic alliance. He was able to agree with all the other things if he needed to go for x-rays and everything, because he had established a therapeutic alliance with Dr. Rahila and Sarah. And then we need to be able to monitor adherence and adjust our treatment plans. So let me take the example and illustrate with a case. This is a 55-year-old lady who has type 2 diabetes, and she's coming for her follow-up. She has obstructive sleep apnea and uses a CPAP, but despite using it, she complains of feeling tired, which is not uncommon for our patients with diabetes. She is suboptimally controlled, A1C is 9. She has her diabetes complicated with neuropathy, with issues also living with obesity, BMI is 35, has hypertension and dyslipidemia. She has the whole package. She recognizes that she's not really taking care of herself. She reports that she's very stressed at home and at work, and her patient health questionnaire, the PHQ-9, shows that it is 12, noting that she's got moderate depression, and she admits that she's not taking her medication regularly. Hands up, people who've seen patients like this, right? That's the majority of the patients that we see in clinic. So why do patients stop or never take the medications that we prescribe them? What's the problem? Is it us? Is it them? Okay, so there are lots of factors that contribute to that. 5 dimensions, actually. There may be a social and economic factor. It may be related to the healthcare system. It may be related to the disease condition, the therapy itself, or the patient. Patient-specific factors. I forgot to take the medication. Common, we're human beings, right? Maybe I'm supposed to take a weekly vitamin D supplement. Friday came, I forgot about it. Beliefs about effectiveness. So, if I don't believe that the medication is going to work for me, why would I take it? Side effects. Sometimes they don't tell us, or maybe we don't tell them that as a result of taking this medication, you might experience A, B, C, D, right? Then we have disease-specific, severity. So, patients with prediabetes say, in Arabic, I've learned it's bidayat al-sukkar. And so some patients say, why should I take the medication? Why should I take it? It's, it's a mild disease, but we saw it's not really mild. So the perceived importance of the disease and why they should take the medication is also important. Medication specific, the complexity of the regimen. If I have to take 10 tablets 10 times a day, it's going to be impossible to do that. What about the side effects of the medication? Are they tolerable? And then there's, of course, the social and cultural context as well. Stigma. There are some children who refuse, or some adults who refuse to take the insulin at work because they don't want their colleagues to know that they have diabetes. We still live with that stigma. There's some parents who will say, no, I don't want my child to go with the insulin, at school because I don't want them to know where it is. It's important that, if we need to educate that diabetes is a condition. And I say, it's just like I need to wear the glasses because I have myopia. You also have a condition, but you can live a normal life. So social and cultural stigma is also important when it comes to why there's so much medication non-adherence. But I underline and I put it in red, it's the poor communication as well. And communication is not just about giving or providing information. It is really about having that feedback. Did the person actually engage with that conversation? Do they understand the importance of why they need to make the necessary changes in their life? The other important thing is the consultation time. I don't know about Dr. Rahila and Dr. Salah. How much time do you have for a follow-up patient? High and by. So 10 to 15 minutes. For a new case, maybe we stretch it up to about 30 to 45 minutes. And so how much can you do within those 15 minutes? So a short consultation time is known, and this is a study that was carried out to adversely affect not just patient care, but we don't feel that good either because, it leads to burnout. You feel like I didn't give that patient, what they really needed. And so sometimes it leads to polypharmacy because what happens? Maybe it's a side effect of the medication, but you add on another treatment and you add on, and then it becomes just continue same and continue same. So, a patient's view. Let me go back to the same patient. She says, I want to see my healthcare provider in order to make myself feel better. But she's saying, you want me, she's telling her physician, or she's telling me rather, you want me to keep my appointments, memorize all my medications, and sometimes I get caught off by when I ask the patient, all right, so tell me what medications are you taking? And the patient says, Doctora, ana ma hafadta. I didn't memorize them. Okay, so we also require them to read and use health education materials and manage their care. They see us once every 3 months, maybe once every 6 months. In addition, she says, you want me to take my medications, you want me to reduce my weight, you want me to count carbs, you want me to exercise, you want me to poke my fingers because I don't have a CGM, you want me to check my feet, you want me to get immunized, and you want me to see the eye doctor. That's a lot of stuff that we want our patients to do. And if we cannot communicate that effectively and relay the importance of each and those steps, it is no wonder then that we have poor health outcomes. So adherence and persistence, hand in hand, is one of the major barriers for achieving glycemic controls. And then it's downfall from there on. It's a domino effect. So how do we ask about adherence? I learned that it's not about asking a patient, did you take your insulin? But rather, how many times in a week do you forget to take your insulin? You get a much better response with that. And not frowning about it. I said, I don't take my vitamin D supplement every week. I can tell you that. And it's right beside my bedside table. It's right there. I can see it. But Friday comes and I miss it. So I'm not as harsh on my patients when they say, yeah, doc, I didn't take my medication. And then the role of psychosocial factors in medication adherence. I will highlight about health literacy and numeracy, beliefs about the illness and the treatment. Of course, the behavioral skills and self-control and self-regulation, mental illness, psychiatric illness, and cognitive function all play a role in medication adherence. So we should be able, in that 15 minutes, consultation time, high and by, to assess whether they have symptoms of diabetes distress, depression, anxiety, eating disorders, their cognitive capacities. And then we should, when we identify, include the caregivers and the family in these assessments as well. Now, how many of you are using these tools in the 15-minute consultation time that you have? These are the validated tools. Depression, PHQ. Anxiety, there's the GAD-7. For all the patients, you want to test their cognitive function, there's the mini mental state examination. For eating disorders, you have the DEPS. Do we use all these things? Fear of hypoglycemia, because that may be the barrier as to why the patient is not taking their insulin. I have mothers who say, la doctora, don't tell me to bring it down to less than 200. I won't sleep, right? Okay, so other barriers that are outside of our clinics, right? Social determinants of health. What do we mean by that? The social and community context, the economic stability, whether they can afford the care, education. There's so many things there that play a role. But in terms of, in diabetes, what is it that might result in poor outcomes is food insecurity, right? So if you go to the dietitian and she says, you need to be eating this, that, or the other, can I afford to do that? I want to replace the rice maybe with quinoa. What is quinoa? Okay, it might be a good thing, but it needs to be within the cultural context of the individual. So working within what they normally eat and try and make it healthier. So some patients were not able to prepare their own meals. I see a lot of, the laborers also come into our clinics. And when I say you need to eat this, and I said, doctor, they provide the meals. I don't have a choice, right? So the social determinants of health are also quite important for us to understand. Fluency in reading the materials and the resources that we provide them as well. And then studies have shown that individuals who come from low income status have high risk for hypoglycemia and visits to the ED and hospitalization. Health literacy. Health literacy is the degree to which an individual has the capacity to obtain, process, and understand basic health information. And low health literacy is associated with an increased risk of mortality, frequent hospitalization, and inability to take the medications properly. Because you're not able to read, the pharmacy sometimes just dispenses it, because we don't have clinical pharmacists who can sit with you and say to you how exactly you're to take it. So pharmacists will say, this once 3 times a day, and then writes it for you. But if you're not able to read it, that might be a problem. So addressing health literacy, we need first of all to recognize, and maybe then you need to engage other members of the family to help with the medication. When patients come in, I always ask, who administers the medication? Are you able to take the medicines yourself, or is somebody helping you? Improve the interpersonal communication as well, and then improve the readability of the materials. So our materials shouldn't be like an encyclopedia. Lots of graphs and maybe, pictorial sort of illustrations are much better. And the language has to be such that even a 5th grader can understand. So the other thing is the nutrition labels, right? And it's not just for the nutritionist to be telling our patients this, because this is where the hidden calories come from. And patients may not realize that they're taking those excess calories from the little snacks that they pick up at the gas station. Some of the strategies that we can use to improve verbal communication is to explain, of course, everything in simple language, so using everyday words. Repetition, repetition, repetition. I always say this, I don't know where my diabetes nurses are, but if you've said it the first time, say it the second time and the third time as well. Remember, they don't see us that often. And then the teach back and show me. So the example that I gave about insulin earlier on is exactly that. The patient was given information, but nobody did the feedback to see, did he actually understand how to take the insulin, or where he was supposed to take the insulin, rather. And we want to avoid using, do you have any more questions? Did you understand what I said? That doesn't really help. It's quite intimidating, actually. And then in the last few minutes, I'll talk about motivational interviewing. So what is it? It's a patient-centered counseling style that elicits behavior change by helping patients explore and resolve ambivalence. And it's most useful for patients who are less motivated to change. We heard the word motivation quite a number of times. Those who are, kind of upset and oppositional as well. Why does the status quo often prevail? So you have, I would like to start, doing something about my weight, but it will be difficult. I need to, but it would be unpleasant. I want to, but I'm too busy. I feel better, but it's too hard, right? So there's always that ambivalence. I want to start, but there's something there that always is hampering it. So how motivational interviewing works, it's mainly in patients who are ambivalent and in this conflicted state, and usually something is holding them back about their own self-care. So it's better sometimes to ask rather than tell. And I find it a lot more important to listen rather than give the advice. Because when we listen, and we don't do that often enough, you're able to get the context and the barriers which are actually leading to the lack of self-care behavior. So the principles of motivational interviewing, of course, expressing empathy, which we do all the time, rolling with resistance, developing or managing the discrepancy, and then supporting the self-efficacy. So how do we recognize readiness for change? Recognizing the change talk. I want to lose some weight. I would probably have more energy if I lost, some weight. The importance, the individual has to come up with the answer as, why is it important for me to do that? Why do I need to change my behavior? Confidence, how am I going to do it? And then the questions that we might ask them is that on a scale of 1 to 10, how important is that for you? And a lot of times you will hear, I want to do this because I want to be there standing with my daughter or my son at their graduation. That's important. And always circling back when they're falling off, that this is why you're doing this, in order for you to be at your son's graduation. Right, so rolling with resistance, rather than being confrontational and saying you must do 1, 2, 3 or the other, I think it's a lot of times important to look at why they're not doing it and asking those questions. Why is it that it's so difficult, say, if somebody has to take a statin? What are the things that you think are stopping you from doing it? So I'm running out of time. I only have a minute. Encouraging behavior change. So I like what Sarah did, and it says, it was the example that she said. She said, celebrate with the patient, right? So the little sort of changes that they make in their lives, in the things that they've done when we've advised them, celebrate that with them, however small. So if the A1C was 10 and it's come to 8, yes, we're not there yet, but hey, hooray, we've done well. Language has a strong impact, and people-centered or people-first language. We still use diabetic, and I see that in the file as well, 55-year-old diabetic. It would be really sad if somebody said, Dr. Khadija is myopic. Yes, I have a condition, but you don't describe me by my condition, right? So why do we say obese patient? Why do we say diabetic patient? Why do we adjectivize that, the disease? So it's a person with diabetes. It's a person living with diabetes. Then crafting a staircase to understanding using, language. Changing behavior is tough. It's really tough. And so we need to be straightforward about that. Yes, we know that you need to lose weight, and that change is going to be difficult. Rather than saying, you need to take control of your life, right? Then soliciting the patient's agenda. What concerns bring you in today? A lot of times the doctor has their own 15-minute consultation. I've looked at the labs. Creatinine is all over the place. A1C is all over the place. I have my own agenda in the head. But what is the patient's concern for that day? So it's much better to say things like, let's explore, you know, whatever the issue they have in more detail and what you think is going on. The other thing is about, you know, we have a lot of social media misinformation running all over the place. It's nice to pre-bunk the information rather than dismiss what people say. Oh, you know, whatever people are saying, they're ignorant and they're right. But, you know, you could say that there is a lot of information out there. Some of it is false rumors, but let's explore what really is the truth. So, last slide, the consequences of communication failures. And there are many. I've just listed a few ones. It impacts medication adherence. It affects the uptake of preventive strategies. It may also impact screening programs. It increases patient anxiety and confusion. So when they're hearing conflicting information between different healthcare providers, it can be very, very confusing. My cardiologist said, no, don't take this medication. The other person says, no, you have to take it. And then it may undermine the patient-provider relationship. Sarah pointed out that this gentleman really trusted us, and so he would do anything that we told him. And then it may lead to patient acceptance of incomplete or false medication, information. So if the patients cannot trust us, they will look for other sources to get their information, and sometimes that might be fatal. With that, the statement is keeping patients on track, because that's what Zainab had asked me to do in the first place, really requires effective communication and empathy. Thank you all, and sorry for running.
Of lunch, yes. Thank you so much, Khadija, for an excellent talk as usual.
She also holds several key leadership roles, including co-chair of the 5th Forum for the Women in Research, head of the Global Engagement Department, and acting director of International Mobility Department at the Office of International Relations. Today she will be speaking on a highly insightful topic titled From Curiosity to Innovation, a practical guide to transform research ideas into outcomes. Please join me in welcoming Dr. Bashir to the stage. Please, Doctor.
Thank you very much for the nice introduction. Good afternoon, everyone. I'm really sorry that I had to talk while you are having your lunch. This is something that I never, imagined doing, but just because of the schedule and we're running a bit late, I will try my best to do it as quick as possible. So I've been asked to talk about the journey of taking your research ideas into innovation. The journey is very long, involves a lot of ups and downs, involves a lot of challenges, but it is a very rewarding journey. And it's not only rewarding, but it is very significant. And you know the significance of this journey from all the talks that you heard today and yesterday. So you're talking about the evidence, about challenging the facts and refine what is being sought before. So what I've done, because the journey is very long and it involves a lot of steps, I've tried to use my practical philosophy, which is evolved throughout the years based on observations, collaborations, experimentations, and I've tried to put everything in less than half an hour, almost 20 minutes. Okay, so maybe now while you're having your lunch, thinking about, why we should have research in the first place, why we should care about research. And if you forget about everything that's been presented today and yesterday, based on the evidence that's been provided, what is the main reason for us caring about research, talking about it, doing it? We train ourselves to be better on it. The main reason for that, because whenever we talk innovation, whenever we talk about anything novel, and whenever we think about anything to do with your job now, in terms of medication, smart technologies, guidelines, everything, it has the research as a background. Without it, you wouldn't be able to have any of that. But nowadays we living in the era of, what is in it for me? So we always talk about me. What I'm getting out of this, and just for the people who are wondering what is research to do with you and with your career, it's very obvious that all the promotion, and maybe I'm talking mainly about the university-based kind of career, it is related to how much research you do. But even in your clinic or in your hospital, if you're doing research, you will be known as a critical thinker. You will be known as a person who's able to come up with new ideas. And you will be, ahead of everybody else who is not interested in research. So other than that, if you're now thinking about having higher education, PhD or master, for example, research is a core aspect of that as well. And just maybe if you are interested about making your CV more attractive and having a different status, again, you will be interested in research. But if you are not interested in any of this, you don't want to be promoted, you don't want to have qualifications, so you may still ask what I have to do with this. And if you look at the end here, for a better globe, so as long as you're living in this globe, you should care about research. So just being here, it's good enough for you to care about research. Now, just quickly, we know that our globe is surrounded by a very long list of challenges. The list is getting longer, and the nature and the complexity of these global challenges is getting, even worse with time. And maybe I don't need to go through all of them, but whenever we talk about any global challenges, we always think whose the people are equipped, are gifted by certain skills to deal with these challenges. And as you can see, I will focus on the global health challenges. And whenever we talk globe and health challenges and the large number of population are affected by certain health challenge, we cannot escape diabetes. So just looking at this figure, it's a bit blurred, but showing how, diabetes is very global. It's not about the millions that having diabetes now, but even about, the future and the projection. It's increasing everywhere. So this is just one example of the health problem that we have. But to have such a thing that's everywhere, I think we need a task force. We need manpower. So it's not about the universities, the institutes, and the organization. You need people to do the job for that. And who's the people who are able to do that job? Researchers are the one. So researchers are naturally gifted to identify the gaps, wherever they are, and to find a way to introduce innovative solution. And they do that through a very systematic way, so something that you can reproduce. So any researcher is able to do that in a very kind of consistent way. And the interesting part of it, regardless of what is your background in here, so if you are a clinician or a nurse or diabetes educator, you are able to do research. And this is what I'm going to show you today. Every single person in this room, regardless of what's your background, you can do research and you can provide us with some novel solutions to what we are experiencing. So, what this group of people have in common, I just tried to list what they have. Curiosity is the first thing that you should think about it. Without asking the question, without seeking, what is the reason behind every challenge, you wouldn't be able to do research. But I will tell you, if you are not curious by nature what you can do. So all of this group of people, they are very passionate about what they do. They have patience because I told you the journey is a very long journey, as I mentioned before. They have the ability to think in a different way. They can observe what other people observe, but think differently. And this is what makes them very special. So, and also there is something very important. I told you it's a very kind of diverse experience. But one of the most important things that you have to be a collaborative person. If you don't know how to collaborate with people, it would be very difficult for you to take your research to the future. So, as I mentioned, what we're talking about now, it is not just a hypothesis. It is something that happened a long time back, and it's happening now. This group of people can think of the problem in a different way and come up with a breakthrough kind of discovery. And just here's something relevant to diabetes. 100 years back, you know, Panting and Best, they came up with insulin. Before that, mortality was 100% for the patient. So since that time, or even before that time, in 1800s, the first researchers find out the relationship between the pancreas and diabetes even before insulin secretion. And the journey continues. For the last whatever years, we have people who are working hard to come up with something tangible when it comes to the global health challenges. And just, you know, like a few years back or 10 years back, we have Milton from Harvard discovered that we can use stem cells to produce beta cell, pancreatic beta cell. And again, this came because of the same kind of common traits that these two people having. And I don't like 100 years, but you know, every year, as you all know, maybe this is something very common knowledge, every year we acknowledge researchers and we celebrate their researches and discovery. As you may know, we had a very interesting story this year when it comes to medicine and physiology, the lady who won that award. I will comment on that later on. So we already agreed that we have this group of people who are capable of taking this journey. And regardless what you do, you can be part of this group. Now, to take your ideas, innovative ideas to outcomes, this is where the important part needs to be discussed. And as you can see here, I've tried my best, because as I said, this is a practical philosophy of mine that I'm presenting today. You have the innovative kind of zone, which is the first part. Then you have the systematic process. So regardless of what your question is, research question is, you have to go through a systematic process. And after you do this job very well, after that you will end up with the outcomes that they asked me today to talk about it. So if we look in here, innovative zone, the first part of how you come up with the idea and how you put it into a question that's clear and specific. And after that, you know, like look into what other people have done and how you create something different. This is the innovative part. Once you move to the second phase, which is a systematic process, then things are a bit similar to each other. At the end, when you have the outcome, what you need to do is it, and the step number 10, this is just from me, about celebration, your achievement, and I believe that's very important. So, just quickly, curiosity sparks the research question. But maybe now you are in the audience, you just finished your lunch and you say that, I don't have this, what I'm supposed to do. The good news is we do have innate curiosity and we have acquired one. So there is people who are by nature asking questions, they don't take information as it is, and this is the real kind of innate researchers. But there is, you know, like the training, the continuous training, the continuous exposure to people who are innovative will help you to be kind of, or to acquire this curiosity. So even if you are not by nature, you have an opportunity to have that by continuous education and training. So once we have the, you know, all these kind of ideas jumping in our head, How do you validate that your idea is good enough? Before you go to the validation, I would say that, I tried to put some notes on the right side, so it is practical, It's practical kind of notes. So, whenever you do something routine, you won't end up with any research question. Always pay attention to the thing that's unusual, to the cases that in your clinic setting that you don't see usually. Because anything that is repeated in the same pattern, it's very difficult to develop a question from that, a research question I'm talking about. Then, very important, and we always say that to the students, to our graduates, to our master's student, PhD student, you have to be very close to the literature. Because through having a consistent research literature review, you will always open your eyes to specific kind of interesting places. Also, you have to communicate, and this is very important, you communicate with the people who have the same mentality. So you may say that, I know some people work in places where there is nobody talking about research. What do? You collaborate with other people, and here collaboration coming again to the picture. So please reach out to the people who have this sort of innovative mentality, research mentality, who would like to do brainstorming all the time. And don't worry, innovation, I've put it on the left side, it doesn't have to be like a discovery of insulin, for example. Any sort of gradual improvement in any of the work or in the policies that you're dealing with, in the practice that you're doing in your clinical setting can be like a hot topic for innovation. I told you about literature review, and you have to be very consistent and close to this. I just put this, PubMed is one of the very classic libraries accessible for free. There is more than 39 articles, and if you just type diabetes, you will end up with more than 1 million research articles. And now you may wonder, in the afternoon after lunch, how I'm going to deal with that, how I'm going to do literature review in such a huge amount of work. So I've put some kind of notes for you to make your life easier, because I believe that by the end of my talk, I'll make sure that all of you are interested in research, regardless of what's your background. So you have to be very selective in your research. When you search any literature, you have to be selective, including PubMed. Very specific and narrow the scope. So, for example, if you want to look at any specific question, you have to correlate that to the clinical setting. And inside the clinical setting or clinical articles, you have to find the one that randomized control, RCT, or non-RCT, or cross-sectional. So you have to kind of narrow your scope to find more information. You have to look at it in a, kind of a big picture, try to connect the dots, try to establish kind of pattern. You do all of that while you do the literature review. But at the end of the day, you will end up even sometimes with, say, 50 articles or 50 to 20 articles usually is the reasonable way to start the literature review. But you have to also be smart in reading the literature. Nowadays, even when you submit an article for publication, most of the editors, they don't look at the introduction. It is objective immediately to the methodology and results. So be smart also when you review the literature. Don't spend a lot of time about what is the introduction, because the introduction is something that we already know. Always focus in the research questions, the objective, methodology, and what sort of results that they have. I've already told you it's very important to look into the well-trusted libraries, just such as PubMed or the National Library for Medicine. Another important, the third step is to formulate your question. And that's very important because the research question is the first step for the success of your study. So if you have any vagueness in the research question, that will lead you nowhere. And you don't want to spend, months doing recruitment or doing data collection, and you end up with nothing. So make sure that, again here, a practical note of, how the research question should be, very focused, very clear, very practical as well. So if you working in the clinic, in one of the clinics, for example, and you don't have access to any sort of research other than, medical records, for example, it will be very logical to go for observational study where you consider this as your research model. Anything kind of interventional wouldn't be a good idea in there. So use all of that, and also not to be biased with this question. For example, if you're studying anything to do with gender, for example, it is very biased to look into clinics where there is only females, for example. So you have to make sure that it's not biased when you put that question. This is the fourth step, which is what sort of research model. I think I want to spend a lot of time in here. We divide it usually into clinical, in vivo, and in vitro. But for most of you, I think you will go for the first model, which is the clinical setting. So anything to do with your patients, anything that you can think of it, related to their demographic, related to their clinical data, related to their behavior, attitudes, their adherence to medication, all of that can be a very kind of suitable model for you, since most of you work in clinic. So if I had a different group of audience, I would have discussed the other models, but for the sake of time, I will move on. So 5, this is the design, different designs of your study. Now, it's really, I know, you think about the hierarchy, and we know that RCT is the most powerful kind of research design. However, I'm here to give you this practical kind of philosophy. So it really depends on where you are and what you do. So for example, if you are a person that have no collaboration, please start collaboration, and you don't have fund, and you are not affiliated to any research institute or university, so definitely go for observational design, definitely. And from tonight, if you want to start the process, you can start it by case reports, series of different reports. You can do literature review, narrative or systematic. Both of them are valid. If you have a group of people or a couple of people with you in the same setting or in the same hospital, you can think about analyzing what you have in hands. And in here, you can think about cross-section. It's still observational, but it needs people and it needs time. So you can think of cross-sectional, case control, or cohort, or meta-analysis, just in case if you don't have any enough or significant kind of number of medical records. On the other side, this is the best thing that you can think of. Experimental design is it RCT or non-RCT. Of course, I'm not discussing this. It's not very relevant to use in vivo and in vitro. So be practical, assess what you have on hand, and based on that, do research. Now, the conduction of the study, and I think this is the most important part, because here you implement all the effort that you've done when it comes to innovation, literature review, and selecting the research model and the research design. So this is, you have to spend enough time to get into here, because having a strong start will help you having a good implementation of the study. However, there is some kind of important tips you have to remember. Before you touch any medical record, so before you talk to any patient as a participant of your study, you have to get ethical approval. Of course, if I have a time, I would have given you more kind of recommendation when it comes to ethical application and from where you get it, and all this kind of dilemma. But for now, ethics approval is the first step that you have to have. Again, I highly recommend pre-screening of your population in your hospital or in your clinic before you start to know what you are dealing with. And then data collection, as you collect more data, as you will have a stronger kind of correlation and outcome. Now, moving to the 7th step, I'm getting closer to my 10th step. So, if you want to analyze the data before, if you looked here in the left, researcher couldn't kind of leave, we couldn't do anything without biostatisticians before. But now, the good news is we do have a lot of statistical softwares that can direct you, like SPSS is one of the most popular kind of software that can help you to analyze your data. And more interestingly, these days we have A-based software or A-based tools to analyze your data. We have Julius. I'm not sure if you heard of Julius before or no, but it is a tool that you put your research question, your objective, what you want from the data. It's a matter of minutes. You will get everything in place. Before, we used to chase people to do the analysis for us. Now, we're living in this era. So, in terms of, in general, if you're doing this observational study, you will be either descriptive, we call it descriptive analysis, looking at what you have, finding out, the prevalence, the frequencies, like all these kind of descriptive features. But if you want to do more kind of analysis, you will go for something deeper, which is like, t-test. Maybe I'm not a biostatistician, but, definitely you heard about t-test, ANOVA, t-test if you want to compare two groups, ANOVA if you want to compare more. If you want to do kind of prediction, you go for linear regression analysis. Sometimes, or most of the time, if you want a very comprehensive kind of analysis, you go for a mix of all of that. And I think we are lucky just for the reason that we do have AI-based tools help us with that. So, getting to the 8th step or the 8th step. So, assuming that you've done an amazing kind of study, you got the data collection, you analyze it using different tools, then what you're going to do is your discussion. Now, the good news about that, there is no right or wrong when you discuss your outcomes. Your outcomes are your outcomes. As long as you've asked the right question and you use the right research methodology, definitely what you have, it is worth kind of discussing. So either you're confirming your hypothesis, or you're challenging it, or you're refining it. All of these aspects can be discussed in a kind of comprehensive way. And please pay attention to the notes, the practical notes again. Start with the significant outcomes regardless if it is expected or not. Make sure that you do it in a context. So always what's been done before needs to be kind of considered in the discussion. Thank you very much for turning the time on. I just noticed that I have 1 minute left, so thank you for that. So make sure that you discuss all the outcomes in the right context with whatever been done before. So number 8, share your outcomes. And I think, I want to highlight that the only job that you do, and it will stay forever, is to reserve a spot in the scientific community. So by publishing even one paper, your name, your ownership will stay there forever. So this is one of the very important aspects. Once you have outcomes, you have to publish it. Of course, presenting it, you can presenting it in different places, different conferences, seminars, and all of that. But publication and share it with everyone around the world. This is the most rewarding, most important experience that I think every single person should kind of experience. Last thing, these days we have the online and social media. There is actually a matrix, they call it Ultra Matrix. It tells you how much your work is being viewed and shared and all of that based on this online. So pay attention to that as well. It's becoming something very important. Now, this is my 10th, and I think it is very important to celebrate your achievement. It's very important because this is the energy that will makes you move on, will makes you to keep doing research, because research has a process. It's a very lengthy process, full of ups and downs, a lot of disappointments sometimes, but by celebrating everything that you achieve in this journey, will keep the process going. And regardless if it's 1 or 100 publication, we learned a very interesting kind of lesson from the winner, Dr. Mary, from the winner of physiology/medicine, Nobel, who proved to the whole world it's not about the number of publications that you have, it's about the quality of research that you do. She won it with a very kind of small number of publications. And at the end, I would like to share, I have 2 slides and I'm done. Sorry for the delay. I have 2 things that I want to share with you. To sustain research, we developed this tool in which we can, from the publication that we have, we can predict the future of research in diabetes. And I can tell you now, if you are excited about research, I hope you are now, and you want to start, this is the future. Anything to do with AI and diabetes complication is becoming a very trendy and hot topic. Anything to do with non-invasive tools, whatever it is, saliva or something else, it is the future. Integration, different kind of omics data is also something that you have to pay attention. Maybe the last bit is for basic research. So this is something else. We started continuous education in research. It's called Create Webinars. It's available for everyone, and you can get it. You can get CME credits as well. So, at the end, if you've never done research, please start it. It is so worth it. If you already are a researcher, I know many researchers in here, please keep doing it. It's very important that we have capacity for research and researcher. It is also worth it. And if you are an expert researcher, please make sure that you pass it to the next generation to collaborate together and sustain research. I'm done. Thank you very much for the attention.
Thank you, Doctor. It was a rather insightful lecture. Any questions? Can take one question. One question.
No?
Okay. Thank you, Doctor.
Thank you.
Let me invite Dr. Khadija again for the symposium. Optimizing patient outcomes, the role of CGM in the modern clinical practice. Please stop.
So, assalamu alaikum, and she introduced me as Dr. Khadija again. I hope you don't get tired of hearing my voice this afternoon. Right, so we're going to have, I think, 2 symposia back to back, and I'd like to thank the organizers and first Sibionics for asking me to do this symposia. And part of my talk is going to be somewhat, slightly a repetition of what Dr. Ahmed has already talked to us earlier. He gave us a fantastic talk on diabetes technology. There was a lot that he talked about that's there to come, but I'm going to take one step back and just talk about the nitty-gritty and the sort of things that we can do now. So talking about how we can integrate CGM, which is continuous glucose monitoring, into diabetes care. So we'll talk a little bit about the CGM technology, utilization, and ensuring how we can get the optimal success with it. So we know that there's at least 42 factors that affect glucose, right? It starts from what we put in our mouths, the medication that the patient is on, the amount of activity, their biological stresses as well, the amount of sleep that we get, the environment, even the temperature sometimes, the altitude. And then there's behavioral and decision making as well. So there's lots of things that can affect glucose levels. And we always strive for our patients to have a better glycemic control. So there's this triangle where we're striving to improve the hemoglobin A1C because we're using that as the marker for diabetes control. But it's important that we do that by making sure that we don't have too much hypoglycemia, and we want to limit glycemic variability as well. And we know that in clinical practice, that is a difficult feat to attain. Now, you're all aware of this. You still have patients who come in with the diaries with, you know, a lot of scribbling there, and there's a lot of limitation on that. There's no information on the glycemic variability, and a lot of times these diaries miss hypoglycemia frequency. So just to kind of, and I apologize that I'm giving you the basics here. I know a lot of you are using these devices, but for those in the audience that are not well versed with it, the difference between the self-monitoring blood glucose and the CGM is that with the self-monitoring, we're mainly measuring the capillary blood glucose. It provides very sporadic data. It provides just a snapshot of the blood glucose at a point in time, and it can be extremely burdensome for patients because you have to poke your fingers, and it's quite painful. On the other hand, with the CGM, it's actually measuring the interstitial glucose, so that's also something that's important to tell our patients. It provides real-time or retrospective blood glucose data, and it can give us trends. It provides us an insight into the trends, and then we're able to pick up hyperglycemia and hypoglycemia. So I always tell my patients, if you want to go to Africa on a safari, the best way to see the animals is actually from a hot air balloon, right? Then you'll be able to see all the animals. Whereas if you go with your Jeep, you might spot a giraffe, but you miss where the lion is. Right, and now it's being increasingly incorporated into our clinical practice. So what sort of data do the CGM devices provide us with? So there are a number of key metrics that we need to be aware of or are aware of. First of all is the percent of time that the CGM is active. We have a glucose management indicator, which is kind of like the equivalent of the hemoglobin A1C. And also we have a measure of the glycemic variability, which is very, very important. And less than 36% is considered acceptable. And then we have the different ranges, and we refer to this as time in range. So in target is between 70 to 180 milligrams per deciliter. We want to avoid both level 1 and 2 hypoglycemia, so that's time below range. And time above range is anything above 180 milligrams per deciliter. So this is just what I've mentioned, and we want as much as possible for our patients to have the time in range, and as Dr. Ahmed talked about earlier on, time in tight range is also something that is becoming more popular. So the AGP, or the ambulatory glucose profile report, gives us these metrics. And you can actually, it is a very simple traffic light system that is easy then to explain to the patients. And I say to my patients all the time that I want to see more green, less of the reds, and less of the other colors. And here's an example of a patient who's not doing very well. As you can see, the time in range is only 47%. It gives you other sort of information, the daily glucose profiles, and then you can go over it with your patient to actually tell what is the exact problem, and therefore then you can address it with them. We have some international consensus on what should be the time in range for different populations. So for individuals with type 1 and type 2 diabetes, more than 70% target range, so for 70 to 180. For older individuals, because we know that they may be more prone to hypoglycemia,
more than 50% time in range might be acceptable. And then, of course, in pregnancy as well, we want to have a higher time in range so that they don't have the complications during pregnancy. What is the significance of the time in range for glycemic control? The time in range and hemoglobin A1C complement each other, and the time in range actually can predict the development of complications, so retinopathy, cardiovascular disease, and so on. Now, why we talk about time in range and we shouldn't rely so much on the hemoglobin A1C, because what we've learned is, as you can see from these three graphs, these three patients, all of them have the same hemoglobin A1C, it's 7%. And so if you were to just rely on the hemoglobin A1C, you would say, well, this patient is well controlled. But now if we look at their time in range, time below range, and all that, and you can see quite clearly that these two patients are not doing as well as this patient here, as his time in range is 100%, and therefore A1C of 7%, but the other ones are having these all highs and lows, and it averages off as a normal HbA1c of 7%, but that can be very deceptive. So again, it's a bit like when you're trying to take a picture through a keyhole. The information that you have with the CGM is just so much more expansive than you would with the old methods that we still use, unfortunately. So in terms of the recommendations, who do we recommend should be using a CGM? Well, anybody who's using insulin therapy should have the privilege of having a continuous glucose monitoring, irrespective of how the insulin is delivered, whether it's through injections or through a pump. And irrespective of the type of diabetes. So if you have type 2 diabetes and you're on multiple daily insulin injections, you should be privileged to have a pump as well. We know that now the recommendations are also probably recommended for GDM not on insulin, and for type 2 diabetes on less intensive insulin regimens. The evidence for intensive insulin, we know that there have been lots of studies that have shown the clinical efficacy of CGM, particularly in type 1 diabetes, regardless of the delivery method. And it should be now the standard of care. Anybody with type 1 diabetes, should have access to a CGM. And the work that was done by right. Okay. Right, so he did tremendous work in terms of advocacy and made sure that every single individual in the UK with type 1 diabetes is given access to a CGM. There's significant reduction in hospitalization and acute diabetes-related events and absenteeism as a result of introduction of the CGM. We know that the benefits it provides is not just in terms of glucose control, but increased engagement with the diabetes care team, because you have to have that conversation with them. It is a relief from the cumbersome of having these intrusive finger sticks, and more information is available that then you can work on with your patient. This is a meta-analysis which Dr. Ahmed had also showed that there's improvement in time in range with the use of continuous glucose monitoring. The American Association of Clinical Endocrinology also advocate for the use and advise real time when there is problematic hypoglycemia, or you can use the intermittently scanned in individuals with newly diagnosed diabetes, primarily as an education tool to motivate people and to reduce the risk for hypoglycemia. The mobile study was one of the studies that showed how CGM can actually be useful in individuals with type 2 diabetes who start with a basal insulin, and it demonstrated that there was significant improvement versus the traditional blood glucose monitoring across both primary and secondary outcomes. And then when these individuals were taken off the CGM, their mean A1C actually was seen to go up. So there again, showing that the CGM is not just useful in individuals with type 1 diabetes, but it can be equally useful in individuals with type 2 diabetes. This is a slide that I got from Dr. Mohammed, and he shows how CGM can also help people with lifestyle modifications. So you may have pre-diabetes or diabetes or just newly diagnosed diabetes. One, it can help you to make those behavioral changes in terms of your diet and exercise, because it can show you the relationship between your glucose excursions and what you've eaten. So that's very important, and then you can make the necessary adjustments. I, for one, when I was at the ESD last year, I was offered the Dexcom and I put it on, and I found out that I can't take bread. The minute I take bread, my glucose spike goes to 200. So I've eliminated bread from my diet. What about exercise? Real-time readings can also highlight the impact of exercise on the blood glucose levels, and it might then encourage individuals to take up more activity. So the continuous glucose monitors usually measure, as I mentioned earlier, from the interstitial fluid every 1 to 5 minutes. And it records the glucose every 5 to 15 minutes. The components include a sensor, a transmitter, and a receiver. It's usually worn for 7 to 14 days, depending on which device it is, and it can be used then as an alternative to the finger sticks. So what about their utilization? How do we ensure success with the CGM? One is to review the patient's situation, analyze their glucose profile, engage with them, and then you can explain what we mean by time in range, above and below range, discuss any sort of potential causes, and discuss the medication adjustments around their glucose targets. Now, some of the challenges that patients face, of course, is cost and coverage. So not yet as a policy given to everybody. Insurances are not covering everyone, unfortunately. There may be some psychosocial resistance sometimes, and therefore giving them a trial period with samples can be very happy. I had a patient who resisted the CGM for quite a while, and then when I finally convinced her, she said, "Doc, why didn't you tell me earlier?" And then there may be concerns about sensor longevity, adhesion, device falling off, and so on, but those are easy things to manage. For the provider, we have challenges as well. Sometimes there's lack of integration between the data and our electronic health record platforms. Coverage is inconsistent. So I have 2 patients, both of them with type 1 diabetes. One has a CGM and one of them doesn't because the insurance doesn't cover it. You might say that maybe it causes an increased work for the staff because you've got to be trained on how to read the data. You've got to have the time to actually sit down, look at the data, what does it mean, and then have that conversation with the patient. But the results that the patients have in terms of improving their glycemic control is much, much more rewarding. So skin issues, this may happen sometimes. And there's ways to get around that. Sensors falling off, that can happen too, but you can have adhesives that can help, and you have these colorful bandages as well. So I've already talked about the benefits of CGM. The challenge is, which one do we use? And the first thing that you want to make sure is the quality of the device. So the factors that you need to consider when you're choosing the CGM is accuracy and reliability. And Dr. Mohammed already talked about the MARD, which is the mean absolute relative difference. Is there clinical validation? And does the device require any finger stick calibration? Some models still do, or is it factory calibrated? I won't go into this because you've already heard about how it's done. And then this is just a comparison of some of the features that the CGMs offer us, the duration, of course, the warm-up time, the memory storage, whether calibration is required or not, and the MARD, which translates to the accuracy. Other factors that you want to look at is ease of use and wearability. How easy is it to apply the sensor? You don't want it to be a James Bond kit. Is it comfortable? The adhesive doesn't cause any irritation to the skin. What about the sensor wear time? How many days can you wear the sensor before you need to replace it? What about the warm-up time? Does it take hours and hours to warm up before it settles down to give you the readings? And is the receiver required, or can it communicate with your phone's Bluetooth? And then features and connectivity are also important. Does it provide real-time glucose data, the trends, rising and falling blood glucose? Does it have the alerts and alarms of high and low glucose? This is particularly important, in individuals on insulin. Data sharing, can you share it with your healthcare provider? Can the individual share it with other family members if required? And then there's also got to be compatibility with the insulin pumps and other diabetes devices and applications. Cost and coverage is also another important factor when we're selecting them. If one device is the only one that you have in your facility, then that's the only device that you can use. But, cost is also an important factor. Sensor location, durability, and lifestyle fit. Where on the body can you put it on? Is it just your upper arm? Can you use it elsewhere? Is it waterproof and water resistant so that, if you need to go swimming, showering, there's no problem with it? How discreet is the device? So that's also an important feature. The smaller it is, the more acceptable it is for the patients, and how the device can handle daily activities of living, sports, travel, sleeping, etc. So there's a lot that's out in the market now. These are just examples of the things that are available. We have the Libre, Eversense, Dexcom, and we have the Sibionics that has recently come into the market. And so I'll talk a little bit more about that. I've had the privilege of using it in some of my patients, and I must say that the MARD is very acceptable. These are the sort of features that you have, like all the other sensors, a sensor pack and an applicator. And then the sensor and transmitter are integrated. It's free from finger prick calibration, and that does give you real-time monitoring and storage of glucose data. The size of the sensor is about the size of a coin, so that's quite small. The needle insertion is very soft. It's just 5 millimeters and therefore very comfortable to wearing, and it stores glucose data for about 14 days. Most of the features that you find in the other previous glucose sensors are also featured here. And so you have your alarms as well for highs and lows that can be set. The AGP report can be downloaded and shared with the healthcare provider. And more importantly, you can share it between family members as well. So that allows for remote patient management, viewing and comparing the real-time glucose, and looking at the AGP reports as well. It has received certifications both internationally and here locally by the Ministry of Health. And the product portfolio, as is shown here, there's a lot that's coming out in the pipeline. We know already that it has got a high accuracy. There's no calibration, real-time glucose monitoring. The glucose watch, I think, is going to be coming, and they also have the glucose and ketone monitoring, which is going to be launched, I'm told, shortly. What about the software support tools? It's developing a series of software support tools that we're looking forward to use and incorporate in our clinical practice. So this is the sort of checklist for selection of a CGM. First and foremost is the accuracy, so you look at the MARD, warm-up time, the wear time for the sensor, alerts, alarms for high and low glucose, data sharing and smartphone compatibility, integrating with other pumps and other tools. The cost, of course, is important. The local availability and support here in the UAE. The size, whether it's comfortable, the adhesive, whether it fits in with patient's lifestyle. training and support, for any troubleshooting is also important. And I've put in yellow insurance and coverage because sometimes that's the most important factor that is involved. But this is sort of the checklist for the CGM, and the Sibionics one, at least in my experience now with the use in the patients that I've given the samples to, does tick all the boxes. And with that, I'd like to thank you for your attention, and I look forward to any questions if there are any. All right, so if there are no more questions, I'll move on to the next symposia, because one was supposed to be before lunch and the other one after lunch. The second symposia is really to look at how we can empower patients through education by introducing the My Health Partner. This is a symposia that's sponsored by Sevier, and I'd like to thank them as well for giving me the kind opportunity to present this. So, yes, there's a question? Okay, right.
For the presentation, just I want to add, if I may, 2 things about Sibionic. I'm using it now. I have over 150 patients on it. Okay, the accuracy, it's really good. Okay, and we compare it with the blood. The other things in the application, there is 2 more things I want to add. One, there is food pooling, which is you can do check the carb count from it. You can add rice, how much gram, and it will tell you how much carbohydrate. This is one thing. The other thing is you can take picture of the food. Actually, I did case study on that because before we will keep fighting with the patient, I took only labne, which is when I present there was oil, and she can rehearse again telling me this is only labne and protein bread. Though there was oil and there was also there is nuts, so it changed dramatically the glycemic index. So it will help a lot if the patient take just a picture of the food, and it can tell a lot how the glycemic index changed that time. Thank you.
Excellent. Thank you very much for that insight. Thank you very much. Okay, I don't see any more hands going up, so I'll carry on with, in the interest of time, to the next talk, and this is really how we can empower patients through education. The theme of the conference over the last 2 days really has been on education. So these are my disclosures. And we know that diabetes is associated with a lot of complications, both macro and microvascular. And the key pillars in diabetes management is really to intensify glycemic control, early multifactorial risk factor intervention, and then making sure that we address cardiorenal protection. And the basis or the backbone of all the treatments is always around education on lifestyle, education on weight control, on monitoring, on review. Without the education, all the other pillars don't really have a foothold. So how do we modify cardiovascular risk in people with type 2 diabetes? The cardiorenal metabolic approach is quite simple. The carousel revolves around making sure that we are controlling glycemia, making sure that we address blood pressure and dyslipidemia, making sure that we address platelet inhibition when it is appropriate, and then also making sure that lifestyle modification is always incorporated. And of course, we obviously have to put the patient at the center of all this. Once we've assessed the patient's characteristics, their age, and whatever other comorbidities they are, we need to consider the factors that can optimize their therapy. So, and look at what would be the appropriate A1C target, whether they're at risk for hypoglycemia, side effects from the medication, and complexity of care. We need to be able to engage, have enough information to the patient so that they can participate in the decisions that we make. So it's a joint decision, taking into consideration their social determinants of health, and then putting together a plan that is really quite realistic, providing ongoing feedback and then reviewing and updating that plan periodically. But most importantly, it talks about diabetes self-management, education and support as being part and parcel of that treatment or plan. And what it does, the objective of this is actually to support the self-care behaviors, problem solving, and there needs to be this active collaboration between the healthcare team in order to improve the outcomes and the health status of the patient. So the benefits are numerous. I've just outlined a few of them here. Those patients who are engaged in their care and have, structured diabetes education have less risk for hypoglycemia, have better quality of life. We know that MES can also reduce all-cause mortality. It decreases the amount of diabetes-related distress. It can certainly reduce the amount of emergency department visits and hospitalization and hospital readmission. And the best thing of all is that education doesn't have any negative side effects, or it's an intervention that doesn't have any side effects. So what are the sort of 7 care behaviors that we would like our patients to engage in? And this was actually first set out by the National Standards for Diabetes Self-Management Education by the American Diabetes Educators Association, and then incorporated into the American Diabetes Association as well. And so we talk about healthy coping. So initially when a person is given the diagnosis of diabetes, whether type 1 or type 2, they may be, of course, very anxious. And so how do we help them to cope with a new diagnosis and, reduce the diabetes distress? We need to be able to skill them with how to eat healthy. And so in the multidisciplinary care team, we have our dietary services, how they can be more active. Monitoring of their blood glucose is also important. How to take their medications. Problem solving, and this is, the frequency of the problems, the time in range, the awareness about the acute and chronic problems, and then reducing the risks. So when does this need to happen? It needs to happen at the time when the individual is diagnosed with a condition. It should be assessed annually, or when the person is not meeting their treatment targets, when any complications arise, or when there's transitions in care. So if a child is now moving from a pediatric to adult care, when you have an individual that maybe is moving to another facility, so from one emirate to the other, we should also make sure that the information, diabetes education is emphasized. So I'm going to skip these in the interest of time because I've already mentioned it. But providing really optimal care is so essential. Yet, for physicians, we fail to do that because we see the patients maybe every 3 to 6 months. And that's why the role of the diabetes educator is just so much more important, because you spend much more time with the patient. The frequency of the visits is much more than the frequency of the visit that the patient has with the physician. There are times when patients can disclose information more readily to the diabetes educator than they can to the physician. It has happened so many times that I found out more information about the patient from the diabetes educator. So the goals of care revolve around preventing, complications and really optimizing the quality of life. So there is the idea of having regular surveillance and screening, health behavior modification, monitoring and reviewing, reducing risk for hypoglycemia. But importantly here that they also mention is to avoid therapeutic or clinical inertia. And that means that we avoid either intensifying or de-intensifying an individual's treatment based on their condition, right? So what do I mean by that? Hemoglobin A1C is 8%. We know that we need to intensify. Patients might make the excuse, oh, doc, give me another 3 months. When I come back after 3 months, my A1C is going to be, so there the patient is resisting, and sometimes we give in and wait, and before something is actually done, it may be a year before that patient's hemoglobin A1C is addressed. So last year, I had the privilege of being invited to the Evident Summit, and we then published a consensus paper on improving therapeutic adherence and reducing therapeutic inertia around cardiometabolic diseases. And the consensus was spearheaded by Dr. Wael Al-Mahmid, who is a cardiologist at the Cleveland Clinic in Abu Dhabi. And here I just outline some of the factors that may be contributing to therapeutic non-adherence. And I talked about that in my earlier presentation, that health literacy and education are really important, and we need to be able to address these. And some of these strategies that were proposed is, as you can see right in the center, is to make sure that structured patient education is really delivered at all those points, at the time of the diagnosis, whenever the patient is not meeting their goals, when there's transitions in care, we should be making sure that the patient has the education. So now I'd like to introduce my health partner, and this is something that Servier has taken on as an initiative to help us to incorporate this into our the patient education, acknowledging or appreciating that we might not have enough time in the busy clinics to talk about everything. So this is a website that you can actually point your patients to. It's a simple patient website that has information about all the chronic diseases, diabetes, hypertension, dyslipidemia, ischemic heart disease, and so on. So the patient can just click on whichever disease condition that relates to them, whether it's diabetes, dyslipidemia, or heart failure, and then they can get all the necessary information, and it's done in a very simple way. There isn't a lot of text involved in that, and they can use the website to get a lot more information that they may not get from their healthcare provider. I think there's a video. I hope it plays. I don't know if the technical team. Can you play the video? Yeah. Right, so you can all scan the barcode shown on the screen. That will take you to the website, and then you can pass it on to your patients, to get them to look at it and have more information about that. So I'll just remind you again of the ADCE's 7 healthcare behaviors: problem solving, reducing risk, monitoring, taking medication, healthy eating, healthy coping, and being active. These are the 7 self-care behaviors that we would like all our patients with diabetes to engage in. And with that, I'd like to thank you all for having me for a number of times during the conference. Thank you all for your patience.
Any hands up? I can't see. Okay. Thank you so much. Ladies and gentlemen, good afternoon, and thank you for staying with us for the final session of the day, focusing on evolving strategy in type 1 diabetes. Last but not least, it's my great pleasure to introduce our distinguished speaker, a mentor and inspiration in the field of pediatric endocrinology, Dr. Nando Talanger, consultant pediatric endocrinology at Genesis Healthcare Center and clinical professor of pediatric in Mohammed bin Rashid University. With over 3 decades of experience, has led pioneering research in childhood diabetes and growth disorder. Please join me in warming and welcoming Dr. Nando to the stage.
So you are the diehards, you're here to the very end, so that's very noble. So, okay. So I have no conflicts of interest for this presentation, although it does include a discussion of treatments which are not on label, so just be aware of that, and that's because you can't talk about the future without talking about things that are not already approved. And the cases are hypothetical, but realistic. So I love this quotation from Hippocrates, not the Hippocratic Oath that everyone knows, but actually this is a much better one. Life is short and the art long, and the right time an instant, and the treatment precarious, and the judgment difficult. This is very true of pediatric type 1 diabetes. So we have seen this graph a number of times during the Congress. So type 1 diabetes is a journey from having been healthy with normal glucose levels and intact beta cell function through stage 1 when antibodies appear and beta cells are lost, to stage 2 when glucose starts to rise because the beta cell loss is now not completely correctable, to stage 3 when unfortunately you have diabetes. And the other side of that graph is this. So if we look at this, this shows the decline in beta cells in blue and the blood glucose level in purple. So you see the glucose rises and reaches a peak typically before diagnosis or at diagnosis, which then leads to correction of the hyperglycemia, and that does restore some beta cell function because at the point of diagnosis there are 2 things happening. 1, you have the immune-mediated attack, but 2, you also have glucose poisoning, glucotoxicity. So a very important strategy, a very vital strategy in type 1 diabetes is normalizing glucose as quickly and as effectively as you can, because this will allow your beta cells that are still remaining, 10 or 20% or so, to live longer and keep functioning for longer. And often we see this reflected in the so-called honeymoon phase, and less insulin is needed. But the longer we can make that, the better. Now let me tell you about Ibrahim. So he had been screened for type 1 diabetes as he had an affected older sister with type 1 diabetes. And screening is recommended by the ADA and others for first-degree relatives. Now his initial HbA1c was 5.5, satisfactory fasting glucose, C-peptide normal, but unfortunately he has IA2, GAD, and zinc transporter 8 antibodies. So we know that with 3 antibodies positive, he's got a very high chance of progressing to type 1 diabetes, stage 3, within the next 5 years. So we start him on 6-monthly screening for dysglycemia with HbA1c and continuous glucose monitoring. And the continuous glucose monitoring is now preferred to the oral glucose tolerance test that used to be recommended. That's an excessively expensive and onerous test. So you only do that at the point when you might be thinking of a therapeutic intervention. So you've got a patient who's now got apparently dysglycemia, then you do the oral glucose tolerance test as a prelude to considering teplizumab or whatever therapies may come along in the future. So, and that's the reference there. So at 1 year, unfortunately, his HbA1c has gone up, so he now has dysglycemia. His fasting glucose is also high, and his C-peptide has fallen. It's still within normal. CGM is showing frequent peaks above 140. And if 10% of your peaks are above 140, then you've got an 80% likelihood of developing diabetes within the next 12 months. And if you've got 20% above 140, that means you're going to get diabetes, this month. It's very, very soon. So it's very important to act on this. So he had the oral glucose tolerance test arranged, and as I showed you earlier, that stage 2, is the last opportunity you have to try and do something about this decline in beta cell function and keep the remaining beta cells alive for longer. So what do we do? Here's his glucose tolerance test. So you can see he's got a glucose tolerance test diagnostic of pre-diabetes. So he's not getting a 2-hour glucose over 200, but it's pretty high. So you can see that we're on the clock now. So stage 2 of type 1 diabetes is confirmed, and he's referred to a specialist center for teplizumab. And after 6 months follow-up, after 6 years follow-up, teplizumab has been shown to delay type 1 diabetes by around 33 months. And actually, there are some for whom it's been much longer than that. The studies of teplizumab now stretch out to 10 years, so potentially we could be delaying type 1 diabetes by 10 years in some patients. Not everybody. The average, as I said, is 33 months. So far, teplizumab is the most effective single agent for delaying type 1 diabetes. No one, I think, believes that it is stopping type 1 diabetes from happening. And it relies on inducing immune tolerance. In other words, taming the immune system. But it's still a lion, the immune system. It's still very powerful. And so I asked the question, and I think many people are asking this question, will any single agent be enough? And if you look at the graph on the right, you'll see that there are several agents that have been tried, and rituximab and abatacept do have some effect on delaying onset of diabetes. And maybe what we need is a combined approach, something that tackles the immune system but also takes different approaches. So we have some other drugs in the pipeline, and here you see the approved therapy teplizumab, but we also have other drugs that are in phase 2 trials, so golimumab, abatacept, baricitinib, and verapamil. I'm very excited about verapamil because it's a cheap old drug. Anyone can afford it. And it's been shown to rescue beta cells after diagnosis, so it'll be very exciting to see it at this stage. So here we've moved on to the discussion of stage 3. Teplizumab has been shown to be effective in stage 3, but not yet approved, but the approval is expected pretty imminently. So that will be a challenge for healthcare systems because teplizumab is fearsomely expensive. And if you think it's expensive for stage 2, that's a 14-day course of infusions. For stage 3, it's 2 12-day courses. So I imagine it's almost twice as much. Anyway, this is for the future. We haven't got it yet, but it is expected imminently. Now, the most exciting kid on the block of this group is probably antithymocyte globulin, another inexpensive immune-modifying therapy. So I think there are some very strong developments in type 1 diabetes that will potentially allow us to delay diabetes for our patients. So preserving beta cells, what can we do? So there are basically 2 main strategies: immunomodulation, as I said, taming the immune system, and beta cell protection. And so there's a lot of drugs in development, which I've talked about, some of them, but there are some others here, that, such as azathioprine. And it may be that I think we will come up with a cocktail of therapies that actually is effective. I mean, you know, in leukemia, which is a terrible diagnosis, we use a cocktail of drugs to control it, to treat it, to cure it. And 95% of childhood leukemia is cured. Who wouldn't rather have a cure of their diabetes than an extended period of health need? There are challenges in diabetes. We have a relatively short window to intervene. So at stage 2, the typical duration of stage 2 is 6 months. So you actually have a very narrow window to intervene. If you're going to give your teplizumab, you need to get on with it. And I know of cases where the child has been recognized to have stage 2, but by the time the authorities have finished pondering, the child has progressed to stage 3 and it's already too late. Now, for the patients at diagnosis, they have very little residual beta cell function on occasion, so we don't have a solution for that yet, but it's going to be coming in the future with stem cells. I'm not going to talk about stem cells today because there isn't time. Cost, unfortunately, is likely to be a barrier. I mean, we already know that teplizumab is very expensive, and approvals for new drugs are very costly, take a long time. But what we can do, perhaps, is to consider the use of insulin-sparing therapies, such as low-carb diets. Not every dietitian's favorite. I hope no dietitian is here to throw things at me. GLP-1s, SGLT2 inhibitors, and in the future maybe casdagliatin, drugs that can extend the functional honeymoon by giving you more beta cells to play with. And the better your diabetes is at the beginning, the better your prognosis. But all treatments can be defeated by insulin resistance. Typically we see that in adolescents, obesity, and poor dietary choices. So what about Sarah? She presented with new onset type 1 diabetes, a 2-week history of polydipsia, polyuria, and weight loss, diagnostically elevated glucose, mildly elevated ketones, HbA1c 11.8%, and positive GAD, and hugely distressed by the diagnosis. So many patients that you will have seen, you don't need me to tell you, are just completely devastated by this appalling diagnosis. So I'm speaking of a hypothetical future here, but this is a dream, I have a dream, that she's enrolled in a clinical trial of baricitinib, an immunomodulating JAK inhibitor that's already approved in children down to the age of 1, and verapamil, which I mentioned, a simple old school calcium channel blocker which inhibits beta cell apoptosis. Commenced on MDI with long-acting insulin and ultra-rapid insulin with carb counting. And how does she do? Well, we know from studies that in principle these drugs are very good at preserving beta cells. And if you can control the glucose, and you have to control the glucose, this is so important. I can't emphasize how important it is to get early good control of type 1 diabetes. If you don't do it by 6 weeks to 3 months of age, you never will, because the beta cells are dead, and you're not going to rescue that situation. So you have to hit hard, and here we can see the relative preservation with verapamil and baricitinib of beta cells over time. And this is actual data from studies. So Sarah's insulin requirement, she's older now, 0.4 units per kilogram per day, so technically still in the honeymoon, C-peptide measurable, time in range 84%, good quality of life, and no serious adverse events. So she can continue on her therapy. One of the things we have discovered in the course of these intervention studies is when you stop the intervention, lo and behold, the beta cells die. So don't stop the intervention. The problem is that we have to continue the intervention at least until we have a better option. So it's like if you had hypertension, you stop the blood pressure treatment, your blood pressure goes up. What's the revelation there? You have a treatment that works, keep doing it. William Osler, the famous physician of the 19th century, said, if what you're doing is working, keep doing it. What about the stage 3 pipeline? I've shown you some of these drugs already. So golimumab is quite a nice one. It's a subcutaneous injection given every 2 weeks, but the problem is it's very costly. ATG is the new one that has recently been reported that showed a remarkable preservation of C-peptide. And you can see that verapamil and baricitinib at the end there are doing pretty well as well. What about adjunct therapies? So this very nice paper from Nature Medicine published earlier this year, they used SGLT2 inhibitors in teenagers with diabetes, your favorite group. And they showed that it was very effective and reduced HbA1c, reduced insulin doses, didn't cause hypoglycemia. The worry, of course, as you know, with SGLT2 inhibitors is that you can get diabetic ketoacidosis, even with normal glucose. So what they did in this study was they put in a comprehensive risk assessment before enrolling patients into the study and instructed patients on ketone monitoring and safety so that they actually had, I think, only 2 episodes of DKA, which from any large group of adolescents is pretty good, I think. So we have evidence for these drugs now. And around the corner, and we heard from Dr. Khadija that Sibionics may also have a combined glucose and ketone sensor next year, but Abbott with the Freestyle Libre 4 I don't know if it will be called the Libre 4, they told me it may not be, but the continuous glucose and ketone monitor is coming, and probably also next year, although whether it comes to UAE next year is another matter. And it measures glucose and ketones in real time. So it potentially opens the door to insulin-sparing therapies that would otherwise put the patient at risk of just not having enough insulin. And I think that's a very exciting development and could transform our management of type 1 diabetes. What about Emily? So well-controlled diabetes for 4 years on ultra-rapid insulin and degludec, but still getting significant postprandial glucose excursions. So what can we do? Well, we've got the evidence. We can commence on dapagliflozin, Forxiga. The dose used that was approved actually in type 1 diabetes before the company withdrew its license application was 5 milligrams. And she had an immediate improvement in her glucose levels, particularly postprandial glucose, and no ketosis. So the thing is, if you're on degludec or a long-acting insulin, the ultra-long degludec is the best because it suppresses ketogenesis. It kills ketones stone dead if you take it. So you have to use it in trustworthy patients at the moment. If we had a glucose and ketone sensor, maybe we could be a little bit more ambitious, but at the moment you have to really be selective about the patients you use it in. But as Siju and Zainab know, I use these drugs in my adolescence with success. So here's Emily's glycemic profile. So this is a real patient, and you can see that the glucose has fallen beautifully. And what has fallen, she had a good fasting glucose, but what has fallen is those postprandial peaks. So it's a tremendous result from that introduction of a new simple therapy. Now, cadizoglytin is a drug that's just gone into stage 3 trials. It might be coming very soon. It's an oral liver-selective glucokinase inhibitor. So if SGLT2 inhibitors cream off the excess glucose into the urine, this creams off the excess glucose into the liver. So it does the same thing, a similar thing of basically reducing the postprandial glucose in particular. It's an orally active, liver-selective glucokinase activator. So you might remember that in MODY, one of the commonest MODYs, MODY 2, is glucokinase MODY, where your glucokinase doesn't work. In this situation, you're activating it, you're switching it on. So you're actually lowering the glucose set point. And that causes the liver to take up more of the glucose and turn it into glycogen and other things. So here's the situation when you don't have diabetes. Glucokinase is doing its job. It's taking the glucose, building glycogen in the liver. In type 1 diabetes, you have very little glucokinase activity, but if you add cadazoglutamine, then lo and behold, you restore glucose regulation to what it should be. Afrezza is also known as technosphere insulin, is an inhaled bolus insulin that's now available in UAE. It's not currently approved in children, but the FDA will make the final decision on it in May 2026, and it's likely to get approval in Europe before then. And that application is based on positive data from INHALE-1 that was published in December 2024. It's shocking how long it takes to get approvals, isn't it? You know, we've already got the evidence that it's safe and effective. Anyway, that's disappointing. But yes, so May 2026, hopefully we'll get that approval in children. It's already approved in adults. And as I say, it's available in UAE. So insulin-resistant type 1 diabetes, also known as double diabetes, which you heard Siju speaking about yesterday. Fantastic talk, Siju, thank you. Insulin resistance is a problem in type 1 diabetes. Every child with type 1 diabetes is to a degree insulin resistant because we inject the insulin in the wrong place. We're not injecting it straight into the liver. We're injecting it subcutaneously in the periphery. So you have to give a relative overdose of insulin to get enough insulin to the liver. And then in puberty, that's greatly aggravated. And obesity will make it worse, and it's much worse in girls at puberty. Also, obviously, if a child is not making sensible food choices or is not active, that will make it worse as well. And the problem is that as you are insulin resistant, you increase the dose, which increases visceral fat, which increases your insulin resistance, and which leads to accelerated complications, again, as Siju said yesterday. So double diabetes is really bad, and so let's look at Mariam. Started on MDI therapy with degludec and ultra-rapid Lispro, quickly achieved excellent control, but at the cost of 12 kilos weight gain. And it's my experience that in the majority of obese adolescents, even those with acanthosis who develop new onset diabetes, I would say 85% of them have type 1 diabetes. They have antibodies. And this makes them doubly at risk. They have all of the complexity of type 1, all of the peril of type 2. You know, with type 2 of childhood onset, you're talking about an 80% likelihood of death or disability by 20 years of diagnosis. So for Mariam, that would be 32 years. She'll be dead or blind or have had an amputation or have renal failure. So it's a terrible, terrible prognosis if you have something that looks like type 2 in adolescence. And we have to treat it like type 2. We can't just assume that because she's got antibodies, therefore nothing else will be needed for her care. We have to treat the type 2 element. There's no law that says just because you have type 1 diabetes, you can't also have type 2. So we commenced her on semaglutide and titrated her up to the maximum dose over several weeks, and this led to a huge improvement in weight, hunger, and insulin sensitivity. and her HbA1c remained excellent. She had achieved good early control, and that's terribly important, but you have to maintain it. And time in range, 88%. I'll take that. You know, Siju knows I'm fussy, but even I'm okay with 88%. I prefer 90, but... so treatment for double diabetes, you need to reduce the insulin doses. Now, there are things you can do that are not involving therapy. You can go for a short walk after eating. That causes something called insulin-independent glucose uptake. Has to be immediately after eating, 20-minute walk, easy peasy. But will everyone do it? No, not in UAE, not after every meal. Low-carb diet, well, that's an interesting approach. Why do people lose weight on low-carb diets? It's because they're eating less calories. If you eat less calories, you will lose weight. And that's not a great thing if you're a child who's growing. So children don't grow on low-carb diets unless you give them adequate fat and protein intake to atone for the missing carbs. And most children don't want to eat a high-fat and high-protein diet, unless it's accompanied by ice cream, maybe. Insulin pumps are a good way of managing insulin resistance because you only need about 80% of the insulin that you would do if you were on injections, and that may be a good option in any case, given that we're in this new world of a hybrid closed loop. We need to absolutely, and I endorse what Dr. Khadija said about the cardiometabolic risk, you have to be merciless with the cardiometabolic risk in pediatrics. We think it's not important to us, but it's jolly important to that person in 10 years' time when they've got hypertension and renal impairment. So, you know, you have to really aggressively manage high blood pressure, lipids, and other associated features like hyperuricemia, which is an independent risk factor for early complications in diabetes. And then, obviously, we have the option of considering adjunct therapy. So what can we do? Well, metformin has been used in the past, and as Siju showed yesterday, and I think probably would be regarded as a sort of quasi-first line, given that there is no actual published guideline on the management of double diabetes. But the problem is that the benefits are not sustained. You might see a short-term benefit, perhaps up to 6 months, but then it's not doing anything anymore. I've never had any patient who's really stayed on metformin with type 1 for any length of time. SGLT2 inhibitors, I mentioned, and those are supported by multiple studies in type 1 diabetes. And then we have the GLP-1 analogues, and these are already approved for type 2 diabetes over the age of 10. We have liraglutide and dulaglutide, Trulicity, as you can see on the right there, that are approved in UAE. And in fact, very interestingly, Mounjaro recently was shown to be effective in a study of children down to age 10 with type 2 diabetes. So they had dramatic reductions in HbA1c and weight, and it's even more effective than Wegovy. It's approved, so Wegovy, it says approved for obesity, that should be the drugs below are approved for obesity. So liraglutide 3 milligrams, which is not currently available. Semaglutide 2.4 is also approved, and we've had great success with that. When I was in Al Jalila, we had many patients on semaglutide. Amylin has been evaluated in adolescents. Amylin is pramlintide is the drug name, but it's been withdrawn, it's not available anymore. It does work, but it's no use. It's too onerous to have a separate injection of something else with every bolus injection you do. So, what do we have? Well, we have for insulin-resistant analogues. I think we'll be looking at Mounjaro perhaps as a good option in these cases in the future, and at the very least we have semaglutide now. So what about Shaker? type 1 diabetes for 5 years, very insulin resistant, on the Omnipod, but she's using over 200 units within 3 days, so her pods aren't lasting. And she's distressed by her weight gain, and she wants to stop the pump, but we know the pump is the future. You know, don't stop your pump just because we can figure out things here. HbA1c is not good, and she's got 2 past admissions with DKA. So what we did was we added, and I think Siju covered this case yesterday also, so we added Ideglira or Zoltify. So this is a combination of liraglutide and degludec, both approved in childhood, liraglutide down to age 10. And the liraglutide improves the insulin resistance. The Tresiba element replaces part of her basal insulin through the pump and allows her pump to last for 3 days. HbA1c improved to 7.7, weight reduced, and so we could even consider adding in dapagliflozin if we need to do more. So this is the end of the journey that I've taken you through. I hope this is what I think the near future should look like. Whether it does look like this is another matter. But we've discussed the pathogenesis of type 1 diabetes, early intervention in pre-type 1 diabetes, and the disease-modifying therapies in established disease. The use of adjunct therapies, in particular in double diabetes. So thank you for your attention, ladies and gentlemen. It's home time. Almost.
Ladies and gentlemen, as we conclude the first Emirates Diabetes Educator Society conference, I want to express my deepest gratitude to every one of you who joined us over those 2 remarkable days. To our speakers, moderators, and my lovely educators, to the attendees and sponsors, thank you for your trust, support, and the commitment. I would like also to thank the organizing committee, the team, and Mr. Rafat. Thank you so much for your dedication, your hard work. I know that I was too naggy lady in the last 2 weeks, but thank you so much. It is an amazing work. This is not the end, but the beginning of a new chapter for diabetes education in United Arab Emirates. Together we will continue to grow, to collaborate, and to make difference in the future of diabetes care and management. Thank you so much, and I would like to call everyone for a group picture. Thank you. would like to share the remarks of the second day with you. Certificates. You stayed with me till the end.